along with VC. So the topic of this webinar is management of monochorionic twins. It will be presented by Dr. Jyoti Chandan. Pivotal role of vitamin D3 in pregnancy and lactation by Dr. S. Krishna Kumar. And management of cardiac disease in pregnancy, it will be going to be presented by Dr. V.K. Chelema. So the moderator for today's program, we have Dr. K. Subhash Malia. He is a very renowned personality. Along with his MBBS and DGO degree, he also holds diploma in gynec endoscopy, and he is a consultant gynec minimal access surgeon and DNB guide. He is a member of FOXY endoscopic committee from 2018 to 2021. He is a South Zone coordinator from 2015 to 2018. He is organizing secretary for National Yuva IH 2018. He is organizing joint secretary for South Zone Yuva Foxy 2015 and AKCOG 2016 also. He has published 4 papers in Index Journal and chapters in books. So I would like to invite Dr. Subhash Malia to do the honors.
Yeah, thank you very much, sir. Thank you very much, Mr. Amit. And I would like to welcome everyone for this wonderful webinar we have organized on behalf of Calicut Society and with Torrent Pharma. The first speaker for the day is Dr. Jyoti Chandran, and I would like to inaugurate my co-moderator, Dr. Reggie Mohan. Over to Dr. Reggie Mohan. Dr. Reggie.
Hi, hi, Subhash.
Yeah. Dr. Reggie is Associate Professor at Government Medical College, Trivandrum, and is a good friend of mine. Sir, would you please like to take over and start the proceedings?
Yeah. Thank you, Subhash. Thank you, Subhash. Hello, Krishnamurthy sir, Chelema madam,
Yes,
Jyoti madam, and all those.
Good afternoon, everybody.
Oh, good afternoon. Good afternoon.
All those who have logged in. We have a wonderful academic piece coming over. And the first speaker, I have the pleasure to introduce my colleague, senior colleague, and professor and HOD of Idiki Medical College, that is Dr. Jyoti Ramesh Chandran. Madam is the additional professor in OBG and HO, and she is currently HOD of Government Medical College, Idiki. Her main field of interest is in endoscopy and high-risk obstetrics and fetal medicine. She has a lot of international and national publications, and the main post held was she was a treasurer in Calicut OBG Society, then joint secretary of Calicut OBGYN Society, secretary of Calicut OBGYN Society. Then she was president Calicut Obstetrics Gynecological Society in 2018-19, and currently also she is the president of Calicut Obstetrics Gynecological Society. She's a corresponding editor of Journal of Obstetric and Gynecological Society of India from 2017 to 2020. She's a member Institutional Research Committee, Kozhikode Medical College. I welcome you, ma'am, and madam is going to speak on a very difficult topic for the common obstetricians, that is how to manage a MOMO, that is monoamniotic monochorionic twin. I welcome you, ma'am, and kindly proceed.
Thank you, Dr. Reggie. It's a pleasure to be with you all.
Yes, Subhash.
I'm not able to share the screen.
Admin, please help.
Press share screen, which is there, green color in the lower part.
Ma'am, press that share screen. Green arrow is there, no?
Yeah, I'm pressing, but it's not coming.
No, that means the admin has not given the authority. Just tell him if he has to.
Dr. Subhash, can you hear me?
Amit has to be, I think. Yeah, he has
Can
come.
you see it's coming?
Yeah, it is coming.
Coming. Okay. So good afternoon, my dear moderators and my co-speakers and those all who logged in. Today I'm going to talk on management of monochorionic twins. Monochorionic twins itself is a big topic. I'm going to just give you certain practical tips and certain tips for the postgraduates. So here I go. I'm going to discuss this topic on as what are monochorionic twins, why are they different, how to follow them, how to screen them, about the screening for downs, how to investigate, triage for complications, how to identify complication, treatment opportunities, when to deliver them, and what are the outcomes. So as we all know that monochorionic twins develop from a single zygote. They got a single placenta with an interconnecting membrane, which is very thin, which is just 2 layers. But what we should keep in mind is that they are genetically identical, but heterokaryotype may occur. This point is important in the sense of genetically transmitted disease. They can be discordant for structural anomalies also. So this is the T sign by which we recognize a monochorionic placenta. Now we know when the blastocyst divides at 4 to 8 days, you can have an MCDA twin. But when it cleaves at 8 to 13 days, we can have an MCMA twin. What is more important is the chorionicity, which should be determined at 11 to 14 weeks. That's because at 11 to 14 weeks, you find that 99 to 100% accuracy is there. If you do it before 10 weeks, it will maybe just 98%. Beyond 14 weeks, it may be 77%. And in third trimester, it may be as low as 60%. And how do we do it? We find that there's no lambda sign, which is a sign of a dichorionic pregnancy, where the placental tissue grows in between the membrane. Whereas here you have a T sign, and you always supposed to do it at 11 to 14 weeks by a TAS or TVS. But if you have missed it, when in doubt, always treat that pregnancy as a monochorionic. That is what the NICE guidelines say. Now, why are these twins different? They are different because although they are genetically identical, they can inherit disorders which can affect both of them. There is placental vascular angiostructure which facilitates inter-twin blood exchange. Their etiology for both discordancy is different. They have high risk of complications. Some complications are unique to monochorionic twins only. They need closer surveillance and they are delivered earlier than a dichorionic twin. So when we look at the placenta, we find that the placental cotyledons, cord insertion, vascular pattern, vascular anastomosis, they all vary in different type and number and direction. You can have an AV shunt or you can have a VA shunt. So when you look at this placenta, you see the yellow color is the artery and the green color is the vein. You find that there is AV anastomosis, there is VA anastomosis. And here you find it in a diffuse pattern. Here you find it in a magistral pattern at some places. So this may vary in various pregnancies, and unless we are able to find out this problem, we cannot help them out. So there are 3 equators when you look at the placenta. One is at the level of dividing membrane, and then there are 2 vascular equators. One is superficial, one is deep. So when we look at the outcomes, what we find that the miscarriage rate is around 75%. The preterm delivery rate is also more than 50%. The IUGR rate is again more than 50%. The fetal defects are more than 80%. All these problems do happen in monochorionic twins. So what do? We have to start looking at these fetuses as early as 16 weeks. And we have to look at them every 2 weeks. And what do you look? You look for the LICA, you look for the growth, you look for the placenta and cord insertion. This cord insertion aspect is very important, which I'm going to discuss over subsequent slide. And you have to look at the Dopplers as early as 16 weeks, the umbilical artery and the DP. And at 18 weeks, apart from looking at all these things, you've got to start looking at the MCA Dopplers. Because if you want to find out anemia, fetal anemia can be detected by MCA Dopplers. And you've got to do a targeted scan and fetal echo. Fetal echo is important to find out the myocardial performance index, which I'm going to talk to you later. And every 2 weeks, we have to find out what findings are evolving, because the findings may evolve at any point of time. Then we should know about the appearing twin, which is more common in monochorionic twins. If you scan a patient prior to 6 weeks, there's 80% chance that you may miss a monochorionic twin. And if you scan at 11 weeks also, there is a chance for undercounting. So we have to be very careful. 11 to 14 weeks, definitely we should be able to pick up. And there is chance for an appearing twin. Similarly about vanishing twin. Now ART pregnancies are more common, and we may find that in 38% the fetuses may vanish, and in spontaneous it is only 7%. So you cannot assure of ART that you are going to carry on twins. So there is an incidence of vanishing twin, and it will also affect the biochemical markers screening also. And this particular condition has no long-term complications which we are aware of. Another thing is labeling twins. Whenever we see twins, 85% they'll be either on the right or on the left. But 15% they can be cephaloid or caudal. So this labeling is important because we want to follow up these fetuses separately. If we want to do a CVS or an amnio, and if we want to do some invasive testing, but we have to remember there's something known as perinatal switch. Although the A fetus may not deliver first, so that may be seen even during labor, this perinatal switch. Then dating pregnancy. If we are dealing with IVF pregnancy, we use the embryo transfer date. But for natural conception, we should use CRL of a larger twin. Now, regarding screening, we find that monochorionic twins have higher incidence of increased NT. And why it happens? It is because of the vascular and the fluid imbalance. They are not at high risk of trisomy 21. Any discrepancy, we should concentrate more on cardiac and other defects. So here you see a twin with NT 4.5, here 2 mm. So in such cases, what we need to do is use an average NT for calculation, because discordant NT is more common, it is highest in the monochorionic twins. Looking at the other screening markers, if you see age and NT, it is only 75 detection rate. Age NT combined screening for monochorionic is only 87 detection rate. So the take-home point in this slide is that the monochorionic pregnancy, there's a single probability for the whole pregnancy with an average NT. But if you're looking at a dichorionic, it is a fetus-specific probability. Now, other markers like nasal bone, there's no difference between MC-DC. If DV and TR, the MC twins, less accurate because of fluid imbalance. But if it is tricuspid regurgitation or reverse A wave, it points to cardiac anomalies. Now, what about cell-free DNA, NIPT? Monozygotic pregnancies can be offered, and the sensitivity is same as singleton. And 94.4% sensitivity you can have with NIPT. Whereas with dizygotic, each individual fetal fraction may differ, and if it is in low in the affected fetus, you can have a false negative results. So supposing you find a screen positive with NT or other markers, what you have to do is you may have to do an amniocentesis. And if you want to do an amniocentesis, you have to do both the sacs. And also it is indicated if there is discordancy in growth or discordant anomaly. The fetal loss rate is 0.3 to 2.2%, and always consider a late amniocentesis. Now, discordancy in CRL. What is discordant CRL means? It is 10% or more difference. You call it a discordant CRL, and that is a marker of selective growth restriction. It is not a predictive of TTTS. So discordant CRL has to be kept in mind and to look for selective fetal growth restriction. But if you find a discordant NT alone, it is only 50% sensitive in predicting TTTS. But if you find a discordant DV and discordant NT, the relative risk is 21 for developing TTTS. And why it happens is because of overload. So this is a study in 2018 November. What they did was they studied NT more than 95 centile in one or both fetuses and TTTS, and CRL discordancy of more than 10% and TTTS. And what they found is that it is not currently possible to predict adverse outcome in monochorionic twins. So the take-home message is we have to be on the lookout for these complications developing if there is difference noted. Now the anomalies. Now structural anomalies, it is 2 to 3 times more, and it may show a Christmas cracker hypothesis. That means if you break a cracker, it may break out into multiple pieces. So you can have a short anomaly, you can have a big lethal anomaly or a non-lethal anomaly. And this could be because of gene imprinting, expression, hemodynamic factors. And what we want to do at this point of time is we have to see how we can make the normal twins survive and prevent a preterm birth. So as I said, the lethal problems can be anencephaly, bilateral renal agenesis. The non-lethal can be open neural tube defect, agenesis of corpus callosum, ventriculomegaly. Whatever be the anomaly, you can either go for a selective fetal reduction or an expectant management. But when you're doing an expectant management, you have to think that there is a consequence of single fetal demise. There is a chance of preterm labor and polyhydramnios. So the patient should be counseled accordingly. Now, if you want to do a selective termination, the best time is 18 to 20 weeks. And you choose a fetus which has got a worst outcome. You do it where there is discordant anomalies or an imminent death of one fetus. And what do? You do a cord ligature or a bipolar coagulation with 20 to 50 watt. And the survival of the other twin is 70 to 85%. So this is a picture showing cord occlusion under ultrasound guidance, local anesthesia, maternal sedation. Post-cautery, what do you see? You see that there's no color in the cord, there's bradycardia, and you've got to coagulate at 2 places. And as I said, you do it after 18 weeks, where the fetal loss will be 3%. If you do it before, you can lose the healthy fetus 41%. So the outcome will be better if you do it after 18 weeks, 70 to 80%. Now, if you find like a discordancy, you can have these 3 options. You can have a normal Leica or an oligoamnios. Then you have to look for anomalies, selective fetal growth restriction, PRN. If it is normal and a poly, again anomalies, and close surveillance for any development of problems. But if you have a poly-oligo sequence, it is TTTS. And when do you call it oligoamnios, where the single deepest vertical pocket is less than 2. If the single vertical pocket in one sac is more than 8, you call it polyhydramnios. Now, as I said, we should look at the cord insertion. Here you see a central cord insertion. Here you see a velamentous cord insertion. And look at this study. In this study, if there is a velamentous cord insertion, there will be 30% birth discordance as compared to without birth discordance. Placental sharing again is more if there is a velamentous cord insertion. So you have to be on the lookout for cord insertion and mention if seen. So when you find such discordancy and everything is okay, you should not be assured. You should always look for complication. Now coming to specific conditions, you see these bubbles. Here you see TTTS, SFGR. That means these 2 are the main problems which develop in monochorionic twins. Others are less. So here you see growth discordancy can be seen in 14%. TTTS can be seen in 9%. Anomalies 10%. Placental vascular 26%. So these are the 2 things where we can do something about these fetuses. Now, why this discordancy? This occurs because of inadequate placental sharing. Very asymmetrical sharing associated with velamentous cord insertion, as I told you previously. And these vascular anastomotic patterns are because of shared cotyledons, increased net transfer to the other tin, and AAVV, they help to balance the blood flow. We find that these anastomosis have a protective effect on the smaller fetus. More blood is flowing to the smaller twin. In practice, large discordance with few anastomosis possible. Monochorionic twins with similar weight discordance may have varying outcomes, which is the rationale for selective FGR. So what do? We start scanning from 16 weeks, from 18 to 20 weeks, 2 weekly scan. At each scan, you do an effective fetal weight. You find out where the weight of the large twin minus weight of the small twin. upon larger into 100 and you find a discordancy of 20%, you find that there will be a perinatal risk. In addition, you should do the fetal Dopplers, umbilical artery, middle cerebral artery, PI, PSV, ductus venosus. And you can classify these IUGR babies into type 1, 2, 3. If it is type 1 with a normal Doppler, you give an expectant management. But if you find that there is absent reversal or there is something known as intermittent absent or reversal, that means at one point of time you get an absent, one time you get reversal intermittently, there is chance for IUFD and neurological damage to the extent of 25 to 50%. And you have to discuss therapy option with the parents. So what do? If it's type 1, you carry along till 34, 36 weeks. Type 2, 3, you have to intervene by 32 weeks with steroids. Coming to TTTS, it is a problem of hemodynamic imbalance, volume overload to recipient, and cardiac evaluation is important in all these conditions. As I said, oligopoly is a must. Maximum vertical pool less than 2, more than 8 will help you in deciding whether it is TTTS. When you find that there is a sudden increase in the abdominal size or breathlessness, it could be a sign of TTTS. When you look at the MO twins, you find 100% AA-AV anastomosis as compared to dichorionics, it is 79 and 93%. So again, when we get a TTTS, we look at the bladder, we look at the Doppler, and we stage. Stage 1 means Doppler, bladder donor visible, bladder donor not visible. Stage 2, stage 3, abnormal Doppler with A is recipient AV abnormal, B is donor, umbilical artery shows absent or reversal. Stage 4 is hydrops and stage 5 is death. But what you have to remember, it is a hemodynamic disturbance. It is not necessarily sequential. That means today, if it was scanned, you find in stage 2, doesn't mean that next 2 weeks it becomes stage 3. It may become stage 5 in next 2 weeks, or it may remain in stage 2 for maybe 6 to 8 weeks. So always we have to document and wait and see what is going to develop and bail out these pregnancies as the gestation age is achieved. Then I talked about cardiac assessment. As I said, there's increased cardiac load, there's AV regurgitation, chances for cardiomegaly, myocardial hypertrophy, dysfunction, reversal of DAV, RVOT obstruction, pulmonary stenosis, atresia. So how do you look at this? This is done by a fetal echo. In the fetal echo, you do something called myocardial performance index, MPI, also known as TEI index. This index will give you about global left ventricular function, which can be calculated by this formula of isovolumetric contraction time, isovolumetric relaxation time about ejection time. So then you can find out the global left ventricular function. And how will it help? Now, these various researchers have looked into all these aspects of the Doppler, of the heart, and come out with various scores. Out of this, the best score they say is CHOP score, that is Children's Hospital Philadelphia, where they are looking into the ventricular function, the various valves, and giving you a risk of mild, moderate, severe. And this correlates with Quintero staging. So by looking at the Doppler, we can stage the disease and stage the condition and decide upon management. And what do? Stage 1, you do an expectant management. Equipoise means at 20 point of time, you may need to take a decision. Stage 2 to 3, prior to 26 week, you may need a selective laser. But after 27, it is serial amnio reduction. And stage 4, it has to be individualized with laser or a selective feticide. Regarding amnio reduction, this is the most common procedure which postgraduates may also do. How much Riker to remove and why to remove? Because it reduces intraamniotic pressure, it improves placental perfusion, it will alleviate maternal discomfort. And how much? With 1 liter for every 10 centimeter AFI. So you have to reduce it to 25 centimeter. But you should remember that it should not remove more than 1 liter in 30 minutes and not more than 5 liters in each session. Any complication like PPRN, preterm labor, chorioamnionitis, abruption can occur. It is very effective in mild TTS and later gestation age. Laser photocoagulation is sophisticated. We do use Nd:YAG laser, and at the end of the procedure, we also do an amnioreduction. Complications of this procedure is there, but it is said that if there is a severe TTS before 26 weeks, you should do a laser rather than amnioreduction. And after doing this procedure, you have to see whether the bladder is appearing within 24 to 48 hours, Leica is becoming normal. And if the procedure is done in well advanced centers, you have 75% survival for a single survivor and 50% for a double survivor. Coming to TAPS, that is twin anemia polycythemia sequence. It is seen in 1 in 20 monochorionic pregnancies. It usually occurs following fetoscopic laser, 13%, within 5 weeks. But in only 3%, you can have it spontaneously. There is no Leica difference, only hemoglobin discrepancy. So how can you find out for any anemia? We know we depend on MCA PSV. So you start looking at the MCA PSV and you can stage it 1, 2, 3, 4. We look at the moms of the donor and the recipient. And depending on the stage, you can have a discrepancy in the hemoglobin postnatal. So you can start, so that is the importance of looking at MCA peak, because there won't be any difference in Leica measurements, and you may be dealing with a case of TAPS. Then what do you do? Again, you do an expectant management. You can give intrauterine therapy if it is going for severe anemia, fetoscopic laser, IUT followed by fetoscopic laser, or partial exchange for polycythemia. Then coming to TRAPS, it is usually happening because of AA anastomosis. It is seen in only 1%. And here you have a pump twin and a recipient twin. And the twin can have 4 morphological types. You can have an acardius, you can have acardius anceps, acardius amorphous, and ecormus. And this happens because of deoxygenated blood going into the donor twin, to the iliac artery. So the upper part of the body is not developed. And here the perinatal mortality rate is to the extent of 35 to 50%. And here there is 30 to 50% chance that the normal pump twin may die because of cardiac failure, hydrops, polyhydramnios. So how can you bail out these? By radio frequency. By radio frequency, you have a 90% survival for them. And how do you find out that there's an acardiac twin? When you do put in a Doppler, we'll find there is a mass, but there is no cardiac pulsation and there is color flow in that mass. And when you see at the direction of blood flow, you will find it flowing towards the acardiac twin instead of away from the acardiac twin. And when you look at the blood flow from caudal to cranial direction in the abdominal aorta, then if you find that the weight of the acardiac twin versus pump twin more than 70%, it's a poor prognostic factor. If there is hydrops, hydramnios, myelocephalus, it's a poor prognostic factor. Again, what do you do for them? You can just give serial amniocentesis, umbilical cord ligation, radio frequency, 90% survival. You can do laser, you can insert a thrombogenic coil in the umbilical artery, or sometimes you may have to remove an acardiac twin. This is a study from Mediscan. They looked at 91 fetuses with TRAP sequence, and they did laser in 27, and they found that 80% live birth rate at 37 weeks with a relatively good birth rate. So you have laser as an effective strategy. Here again, 48 cases, 84% success rate. And when do you do it? You usually do it after 15 weeks. Higher the gestation age, more cycles are required. And this is a study which gives a very good live birth rate and a cord demise of only 12%. Cord entanglement is seen in MCMA twins, mostly by 30 to 34 weeks. You have to do a Doppler and find out these babies. Single fetal demise happens because of acute transfer of intravascular volume. So there can be a co-twin demise in 12 to 25, neurological sequelae in 18 to 25, anemia, cardiac failure. So for these, what you need is a close monitoring MRI 3 weeks post-demise. We know that if it happens in the first trimester, it does not impair development of the surviving twin. So the management depends at which age the demise has happened. If it is near to the term, it's better to terminate. If it is very early, you may have to take other methods. Now, there are risks beyond the fetus like hemorrhage, GDM, breakdown, hypertension, which are of course topic, but we know that these problems do develop and we have to be on the lookout for these problems. When do you deliver elective birth from 36 weeks?
आरो मला नाही माहिती तुम्ही सांगा ना
Monochorionic twin
ते मी नाही
continuing
बोलत माझं
beyond
काम चाललंय
38
इकडं
weeks increases the risk of death. In MCMA twin, we should terminate around 32 weeks with steroids. Both twins should be monitored continuously. 30 to 40% of planned delivery may end up in CS. Always we have to keep a low threshold for CS. This is a study which says that there is no point in continuing pregnancy beyond 38 weeks. It is maybe associated with poor outcome. Low dose aspirin is indicated in twins if it's a first pregnancy, more than 40-year-old, more than 10 years since last pregnancy, BMI more than 35, family history of preeclampsia, and past history of preeclampsia. Preterm labor, we know that preterm labor, they have an increased risk. Cervical length is less predictive. Don't use untargeted steroids. 60% of twins deliver spontaneously by 37 weeks. What doesn't work is the bed rest, no routine progesterone, no role of cerclage. In the absence of other complications, CS has not shown to be improved, safer than vaginal birth for twins in multinational RCTs. So simplified approach for monochorionic twins is early diagnosis, rule out malformation, follow every 2 weeks by fetal Doppler. If suspicious for TTDS, do the treatment. If FGR, do a Doppler and decide on to the management. Uneventful 36-37 terminate. The few slides on trials in twins for postgraduates. One is the Peristat trial, which was done in 2000-2004. They looked at 11 European countries to find out what is the preterm labor rate in these countries. And then they found in Scotland, it's 9%, in Austria it is 12%, 10% extreme premature. And then they said that clinicians in different countries have different approaches to multiple pregnancy. Then there's a Stop It trial where they wanted to prevent preterm labor in twins, and they gave vaginal progesterone gel for 247 and placebo. For 10 weeks they gave from 24 weeks, and they found that there's no significant effect in timing of delivery or IUD before 34 weeks or adverse outcome. Then Stop It 2 trial is going on at present. It is going on at Southeast Scotland. They're doing a TVS at 18 to 20 weeks with cervix less than 35 mm, and they're putting Arabian pessary to no pessary, and they plan to recruit 500 women, and they want to see what happens, whether they go for preterm labor and what is the neonatal outcome. And there's an Esprit trial. They said that threshold for significant board discordance is defined according to adverse perinatal outcome. 18% for both DC and MC without TTDS and 15% with TTDS. And there's a Stoke trial which says that early pregnancy loss is more in monochorionic pregnancies. No difference in mortality after 24 weeks. It may be because we are able to detect and promptly treat complication in monochorionic and plan an early delivery. So friends, see, the technology has advanced. This lady at 75-year-old at Bengaluru is preparing discon with solar. So we also have to use our Doppler judicially and plan a good outcome and give them twin happily. Thank you.
Yeah, thank you, Jyoti madam. Hello.
Yes, yes.
Yeah, thank you, Jyoti madam. Sorry, I joined a bit late because I got stuck with an emergency.
Yeah.
Okay.
And then
Virendra also, welcome,
yeah.
please.
Good afternoon, madam.
Yeah, good afternoon.
That was a nice presentation with all the evidence. Because there are no comments from most of the viewers, on their behalf, I would like to bring out some questions.
Sure.
Like suppose you said that the screening should be especially for aneuploidy in the first trimester between 11 to 14 weeks. Suppose in rural setup, patient may come little late. They may present at 16 weeks. So how do you plan for such patients aneuploidy screening? Like we textbook wise, we have to screen them in the first trimester.
Yes.
Patient who may come late, like
you want to find out whether the triple marker or the quadruple marker will work.
Okay, right. That's one. And how frequently we have to do ultrasound?
The book says 2 weekly because each manifestation may happen very fast or very late. So every 2 weeks for monochorionic twins, we are supposed to do ultrasound.
Okay. So suppose patients do not have any complications, monochorionic, uncomplicated monochorionic twins. Can we modify?
We cannot say uncomplicated unless we do a scan. If you do a scan at one point, 2 weeks later, that may turn to a complication. So they may or may not be. We have to just be on the lookout for them.
Okay. So is there any difference of appearance of complication between monochorionic twins and dichorionic twins?
Definitely, because I told all these complications are specific to monochorionic twins.
The appearance of complications may be little late in case of monochorionic. That's why we have to look for every 15 days.
Yes.
Right? Hello?
TPS occurs as early as 26 weeks. It may not manifest after 26 weeks.
Okay. And another question, madam. See, evidence-wise, there is no role of prophylactic surclass. But we do get patients from IVF centers who have already trained their mind to undergo prophylactic cervical surclass. What do you advise? Because I am a general gynecologist, I am not a fetal medicine specialist, neither I am an infertility specialist. But we do get patients from different ART centers, and they pressurize to take for cervical enclave. What is your take on this?
Yes, there is no harm in doing after explaining the risk. But evidence says that there is no need for routine cerclage. But ART pregnancies are precious pregnancies. And there have been instances where patients have sued the gynecologist saying that they didn't put a cerclage or they didn't give a progesterone.
Madam, here I want to ask a practical tip, question. Like we have people like us who are doing general gynec practice and may not have a very large practice. In all our Foxy MOGS conferences, a lot of people talk about evidence-based things. And they have a lot of maybe a larger database of patients, and they may not be able to do cerclage for all patients. But now suppose evidence always says that unless the cervical length is not less than 2.5, there is no funneling, then cerclage is not required. But most of the time, sometimes we get a patient at 18 weeks, we do a sonography, which is normal. And suddenly at 24, 25 weeks, there is a funneling or whatever. And then it is too late to do a cerclage. So can we have a take-home message for general gynecologists like us? If they have a high-risk precious pregnancy and cerclage, then cerclage, people should know that it also has its problems. Because if cerclage done wrongly can cause induced chorioamnionitis and cause leaking.
Yes.
So for me, what I started doing is if I do a prophylactic cerclage, I do a Shirodkar and at a higher level. So, and with a Mercilin tape. So the chance of this chorioamnionitis and premature leaking is taken care of. And we counsel, it is prophylactic. So I just tell the patient. So, but all the evidence says it is not to be done. That is the problem.
Madam?
That is there.
No, 1 minute.
If it's a high-risk pregnancy,
Dr. Krishna Kumar wants to add something.
No, whether are we talking about evidence of Indian evidence or we are talking about the evidence which are outside India? So we cannot correlate both. I am very skeptical whether evidence in India is too less to really tell us not to do os tightening. And our patients, as Pradhan already said, they are more pressurizing you because for them every medical treatment has to be a final treatment. If you miss and then after 2 weeks they come with the open os, they are not going to just sue you, they are going to even hit you. So
what is your practical tip? Suppose a person like me, should I do a cerclage or not do a cerclage?
Twins, I would advise I will do.
Fantastic. Good take home message.
I will do. Yes.
Jyoti
Madam, second point I wanted to bring about.
There are questions from the audience.
How do you see the questions? I cannot able to see.
No,
only.
I am able to see. I'll ask question, madam.
Hmm.
Sudha, she has put a comment. MCDA single twin single fetal demise at 24 weeks. How to monitor and timing of delivery? Dr. Sudha.
As I mentioned, you have to, after 3 weeks of demise, you've got to do an MRI of the fetal brain of the surviving twin and find out the any problem.
Now, if everything is normal, at what time you would like to deliver, madam?
Maybe 34 weeks, 34 to 36 weeks of giving steroids.
Okay, right. Thank you, madam. Another question from Shobhana Mohandas is, which centers in Kerala do laser treatment for TTTS?
Kerala, I don't know. Mediscan only I know.
Okay.
I think the Amrita people are doing.
I
Dr.
don't know. Subhash,
I think
whether
Dr.
you know
Vivek and
what
Dr.
is doing.
Yeah, I think Dr. Vivek and Dr. Bijoy is doing in Saimar and in Amrita.
Ma'am,
Sinar and Amrita.
Question which has come from Dr. Rajesh, which says that, ma'am, how do you predict TTTS in the first trimester?
As I told you, no, DV Doppler and NT. These
I think
two
we have
things
covered that.
Keep it under suspicion.
Yes, ma'am. Yes, ma'am. And ma'am, I think we have a lot of more questions here. I think we'll take it up at the next session.
Yeah.
Madam, one last question.
Yeah, sir.
Jyoti, ma'am.
Please,
How do you interpret prenatal, non-invasive prenatal testing?
NIPT.
NIPT.
NIPT for monochorionic twins, as I said, will be a better predictor as compared to dichorionic. Dichorionic has got the individual fetal risk, whereas monochorionic it is better.
Okay.
Like a singleton.
Right, ma'am. Okay. Thank you, madam. That was excellent deliberation.
Thank you.
So, madam, 1 minute. Just the last question, because if in monochorionic twin, if the NIPT is abnormal, we have to assume that both the twins are abnormal, right?
Yeah, you should do the amnio.
Yeah. So, can I introduce or welcome the next speaker?
Sure.
Whatever questions are there, we can take it later on. The next speaker is does not require an introduction. Dr. Krishna Kumar sir. He's been our friend, philosopher, guide, and I have looked upon him for all practical tips right from last 20 years of my practice. Sir is president-elect of IAGE, and another 1 week he would have been installed as IAGE president if this corona scare was not there. Sir has been a secretary general of ISAR 2018 to 2020. He is a ISHRE certified reproductive endoscopic surgeon. He has centers recognized for ICOG fellowship, 6 months fellowship in ART and in endoscopic surgery. And he has FOXI recognized centers for infertility and endoscopic surgery training. And he's one of the international faculties in teaching hysteroscopy and IVF. I have learned my IUI training from sir. And sir's talk today will be on vitamin D. Dr.
Thank you.
Sir.
Thank you, Samir.
Pleasure to have you here.
Thank you, Samir, and nice to see somebody from Mumbai.
Yeah.
Introducing me, and that was an excellent, elaborate lecture by Dr. Jyoti Madam on MCMA twins. I think it was wonderful, and I should say that this is my third webinar for Calicut Obstetric Gynec Society in the last 1 month. So either I should become an associate member or I should be taken as an honorary member of Calicut OBGYN.
We have already take you as an honorary member, sir.
But to be very frank, Subhash, amongst the three today, I feel more nervous in front of so many professors. And I am right in front of a medical college, I feel. And of course, the topic today is given to me is something different from what I've spoken in the last two. So I will take you through all to the medical college and teach you vitamin D, which I'm sure we all have forgotten after learning in first year and second MBBS. And
It's
today
important in COVID also.
Yeah.
Important in COVID also. They said vitamin D.
Improves immunity.
Yes, yes. So we will take you through to the medical college because I also learned a lot. Where am I seeing? I cannot see my screen. 1 minute.
Well, till Sir shares the screen. I think I would also like to thank sir for obliging for our society very much, sir, and also would like to thank the sponsors of today's program, the Torrent Company, who have readily agreed for this three informative talks. And we have also taken care of the postgraduates also, since the DNB exams are also going to come in the next 1 month. So I thought we should have something which is practical. So from the practical aspect, we did decide that we will have some sort of talk which will be helpful for the exam going PGs also. So on behalf of this, we would like to wish all the exam going postgraduates the very best. I think Dr. Krishna Kumar sir has just got his screen. Yeah, over to you,
Yes,
sir.
yes. Thank you. So we are going to look at the pivotal role of vitamin D in pregnancy and lactation, something which may be looking a little dull, but after going through some of the literature, I did find that we are ignorant of quite a few things, and very lot of developments are taking in this field, apart from endoscopy and infertility, where we always think only new things can come up. So to take you through to those first year and second MBBS, I wouldn't take much time, but vitamin D, the classical action we all know, it's for basically calcium balance and bone resorption and bone manufacturing. And the active metabolite of vitamin D is 125 dihydroxyvitamin D, which is also called as 125-OH2D. Now, how this really comes into action is what we are going to see. And this classical picture, we know that vitamin D helps in gut absorption of calcium, though the dietary intake is very poor, and its intricate action along with parathyroid hormone. Once the vitamin D and calcium decreases, we know that the parathyroid hormone increases and it releases calcium from the bone, causing bone resorption and increase in serum calcium. So this is very well known to most of us. And we all forgotten that vitamin D exists in two forms, called the cholecalciferol or D3, which is converted in the skin from 7-dehydrocholesterol, and vitamin D, which is D2 or ergocalciferol, which is basically found only in mushroom and yeast. And this manufacturing from the skin, from the 7-dehydrocholesterol, is because of exposure to ultraviolet light, which converts it into 25-OHD, and this has to go into hydroxylation by the liver before it becomes the active form of vitamin D, or what we call as 25-OHD. This again is acted at the kidney level under the effect of parathyroid hormone, which is again hydroxylating it into 125-OHD, and this is the vitamin D which helps in this is the homeostasis between calcium and bone. So there is a very intricate pathway. Vitamin D inhibits parathyroid secretion. The moment vitamin D goes down, parathyroid hormone increases in this blood, and it causes not only bone calcium release, but increases the gut absorption of the calcium to normalize the serum calcium level. So this is just the basic physiology of this vitamin D acts in our body to maintain the classical action on bone and its metabolism. Now, mechanism action is, apart from this, there are nuclear receptors which are present apart from kidney, bones, and skeletal muscles. It is also found in lung and skin. So this vitamin D action on these other receptors at these sites has brought interest to us in pregnancy now. So this biological action is already, we know that it helps in influx of calcium into the cellular and between cells, and opens up all the uptake of calcium in various osteoblast and skeletal muscle. But this added biological effects of vitamin D, which we all do not give much importance, it promotes insulin secretion. It promotes innate immunity of human cell, and it stimulates cell differentiation, and it inhibits cell proliferation. So there are a lot of studies in the literature where if you come across PCO, we know that PCO have insulin resistance, and a lot of PCO patients also have vitamin D deficiency. So whether there is a possible missing link between insulin resistance and PCO is what is vitamin D. Is it because of PCO, or is it the culprit of PCO, is all being studied, and maybe in a couple of years' time we will get answers to this. So that's a very interesting point which I came to know through the literature. Now, because of these non-classical action of vitamin D, there are a lot of non-classical actions. It promotes insulin action and secretion. It does have a lot of immune modulation. It helps in lung development. So it has a big potential to influence many factors in the development of fetus. And that is what a lot of papers have proved what vitamin D can do, or what hypocalcemia and hypovitaminosis produces in pregnancy or during pregnancy. Now, in normal state, vitamin D deficiency is seen, of course, in pigmented skin. Those with high pigmented skin, because of the melanin, will have lesser absorption of sunlight, lesser conversion of that dehydrocholesterol to vitamin D or 25-OHD. Obesity, something very common. People who are immobile have vitamin deficiency. PCO patients, a lot of vitamin deficiency. And amongst the ethnic population, Black women have a lot of vitamin D deficiency because of the hyperpigmentation. Even Indian Asian women in UK, where they have a big study, proved 47% of the Indian Asian women have vitamin D deficiency. And of course, Middle Eastern women, because of their cultural practices, have a higher incidence because of the covering of their body. And it is only in 13% of Caucasian women. So we have to rule that we are practicing in India. So we have very common in a sunny India. So that is something which we all have to realize. Just because we get exposed to sun, of course, most of us do not get exposed to sun at the amount which we should be, but still it is common in about almost 50% plus. Now, the normal vitamin D level, which is measured as 25-OHD level, and we normally tell it as nanogram per ml, is between 32 to 100. That is what is commonly measured as a sufficient vitamin D, and anything below that is deficiency or insufficiency, and excess vitaminosis can also occur and create complications. So we have to be careful about the dose. Now, coming to the maternal-fetal transfer, where we are talking about vitamin D and its role in pregnancy and its effect in pregnancy, we need to know that this, which I've already explained, formation of 25-OHD and conversion of the same in kidneys to 125, it increases calcium uptake in the gut. There is a calcium deficiency in the pregnancy, but in pregnancy, there is already a mechanism where the calcium uptake from the diet is usually increased. Though, of course, one must remember our dietary intake of vitamin D is only 10% of body's requirements, because very rarely we have food which are adequate in vitamin D contents. And this, apart from acting on the mother, the placental transfer of occurs 125-OHD cannot transfer to the placenta, whereas 25 hydroxide D can be transferred across the placenta, and it has immunomodulatory properties. So that is the role which is being thought upon, whether why does it cause preeclampsia, because preeclampsia we know is all placental induced phenomenon, and vitamin D or 25-OHD, which can cross the placenta, has a lot of action in the placenta. And once this crosses the placenta, the fetal kidney converts it into 125-OHD. So normal vitamin D from the mother crosses the placenta, and the vitamin D is formation in the fetus is by the kidney, that is the mother's 25-OHD has to come to the fetus. So if the mother's vitamin D is less, there is going to be less vitamin D in the fetus. And the normal level which has been mentioned is about 30 nanogram per ml is what is mentioned in pregnancy, which is required for a normal calcium homeostasis and other effects where pregnancy is required. So apart from this bone effects, as I already mentioned, there is a lot of data in the literature where say that preeclampsia is very common in patients who are hypovitaminosis D during pregnancy, and neonatal hypocalcemia is going to be definitely a common problem for the reason which I already mentioned, because the maternal 25-OHD goes across the placenta into the fetus, where the vitamin D is formed again by the fetal kidneys. And this hypovitaminosis can definitely cause impaired growth and bone development in the fetus. And a lot of literature says that babies who have been born to mothers with hypovitaminosis have risk of osteoporotic fractures in the later part of their life. This has been published in 2010 itself in the Journal of Bone and Mineral by Mahon et al. And more this was alarming was the fetal lung development and child immune disorders, which have been all related to vitamin D. Lower vitamin D intake in pregnancy has been associated with asthma in the offspring. And a lot of virus bronchitis and respiratory infections are very common in the newborn where maternal vitamin D has been found to be deficient. So this is something which we all have to take care, apart from just thinking about the bone development, because a lot of literature I did find that there is mention about asthma in the offspring wherever vitamin D was deficient in the mother. So definitely this large systemic meta-analysis, apart from preeclampsia and all those bone deformity, did find that patients with vitamin D deficiency have an increased risk of preterm birth. This is a large meta-analysis published in the Public Library of Science in 2017. And another important finding, which in this Indian paper says that the gestational diabetes mellitus, which occurs during pregnancy, it has been found having relationship between parathyroid hormone and vitamin D. 48% of women had gestational diabetes mellitus wherever vitamin D deficiency was compared to only 10% women who had normal vitamin D at GDM. And the frequency of, and definitely needless to say that the parathyroid hormone will be increased in these women. So definitely vitamin D has some role to play. So there are a lot of paper, a lot of studies which are still going on where they say patients with vitamin, rather GDM, should be given routinely vitamin D. So that of course is not yet proven, but there are a lot of studies in the literature where this interest is really taking rather a shoot. Now, maternal vitamin D status, and of course there are a lot of journals which say that patients, and this is from the Journal of Pediatric Endocrinology, patients of rather infants of mothers who had hypovitaminosis had almost 4 times higher risk of developing again vitamin D deficiency compared to mothers who had normal vitamin D. And 96% of this is a British Journal Nutrition study where they found that Indian women have almost 96% deficiency during their lactation vitamin D. And hypocalcemia, which occurs after birth, we have all seen neonatal tetany quite commonly when there is a feeding problem, and that has all been related to hypovitamin deficiency in the mother. A lot of tetany which occurs in newborn can be prevented or corrected by vitamin D supplementation for the mother during a pregnancy, has been proved by the Indian Pediatric Journal. So definitely with maternal vitamin deficiency, all this is potentially preventable with routine vitamin D deficiency. So should we go for vitamin D screening? That is the question. But there is right now no data in the literature to support routine screening of every mother, pregnant mother, because screening of vitamin D is an expensive thing. It's really little more expensive than our routine test, which we do in pregnancy, but at least it should be done wherever you think it could be, as we said, in PCO patients, patients who have had a past history of GDM, patients who have hyperpigmented skin or their skins are always covered, obese people, patients who are immobile, patients who have had preeclampsia in the past, patients who have other gastrointestinal problems which can lead to decreased fat absorption. At least in these people, routine vitamin D screening has been suggested by the Royal College of Obstetrics and Gynecology, but not for every pregnant woman. Now, supplementation. Let's come to the supplementation. Now, how much to supplement, whether normal dose, because there's been a lot of variation which I found, but women who are prone to vitamin D deficiency, a higher dose of vitamin D3 should be given. That is definitely. Now, what is the higher dose and what is the normal dose recommended is what we will see today. Now, this even Cochrane data, because Cochrane usually doesn't touch on these aspects, but I was happy to see even Cochrane talking about vitamin D may reduce the risk of preeclampsia, low birth weight, and preterm birth weight. And vitamin D supplementation could reduce all these. That is what was published in 2016 by the Cochrane data, though their number of studies were less, but this is a conclusion even with the Cochrane library. Now, vitamin D recommendation by many world committees, as you can see, the NIH or the NICE guidelines say 400 IU is enough for patients who are normal. But the ICMR and the Institute of Medicine says about 600 IU, but at the Endocrine Society between 1500 and 2000, the Canadian Pediatric Studies about 2000, but ASUOG also recommends between 1000 and 2000 IU per day should be the dose for every pregnant woman, is the recommendation during pregnancy and lactation as far as vitamin D dosage is concerned. Now, this study, which controlled a randomized controlled trial where singleton pregnancy between 12 to 16 weeks of gestation received various doses of 400, 2000 and 4000, and they measured their vitamin D after about 12 weeks. And what they found was, of course, patients who were receiving 4000, the level of vitamin D above 32 was seen in almost 83%. Patients who were receiving 2000, where the level was almost 71%. But if you're giving only 400 IU, the vitamin D level, normal levels were only seen in 50% of women. So that is something which we have to take care. What is the right dose? Are we giving the right dose of vitamin D to our pregnant patients? Because many a time I feel we may not be even giving. But definitely vitamin D supplementation is recommended, and the dose recommended is of course more or less coming to around 2000. So this randomized controlled trial of almost 5,405 patients published in the JAMA Pediatrics, where they gave 2000 during the pregnancy, they found that these patients had a decreased risk of infants born for small for gestational age, had better growth during infancy, better fetal and neonatal morbidity and mortality, and greater Apgar score and neonatal fold thickness at birth, and definitely the weight and the height were much better than those who did not receive vitamin D. And this another aspect of vitamin D which very difficult to digest, but then they found that patients with vitamin D deficiency had a higher cesarean rate. So that is something which couldn't be explained why there is a higher cesarean rate, and patients with normal vitamin D babies have definitely better weight than those where the vitamin D was not supplemented up to 2000 international units per day. So this was published in the International Journal of Contemporary Medical Research just this year in 2020. Now, as far as as I said about ICMR and this, the recommendation is about 600, but whether is it the right dose, there has been a doubt, and this particular paper by the International Journal of Clinical Medicine recommends that definitely dose of up to 2000 international units of vitamin D should be given for a normal 30 nanogram per deciliter. So it is found to be safe that you up to 2000 doesn't cause hypervitaminosis D or hypercalcemia. So again, published in the Indian Journal of Endocrinology, where they had two groups, or they rather divided into four groups. One group received only about 1000 IU per daily or 30,000 per month, and the other group received 2000 international units, and another group received 60,000 international units vitamin D monthly. And what they found was the third and fourth group, which received 2000 per day or 60,000, had better vitamin D level during pregnancy and better neonatal and better fetal outcome. So friends, to conclude, to tell about the implications of vitamin D deficiency in a nutshell: adverse maternal outcomes, which includes pregnancy-induced hypertension or PIH or GDM, recurrent pregnancy loss, preterm delivery, primary cesarean section, postpartum depression, and the neonatal adverse outcomes are, apart from rickets, craniotabes, decreased wrist ossification centers, impaired tooth enamel formation, and needless to say, vitamin D and calcium deficiency is required throughout their lifetime for women. Childhood, it can cause schizophrenia, asthma, diabetes type 1, rickets. Pregnancy, we know I elaborated on all the adverse outcome, and of course vitamin D and calcium is required for every stage in women to maintain that. Not only a lot of studies today have come up for the cholesterol and the cardiovascular effect of vitamin D, including obesity, and as you grow older, definitely vitamin D is definitely required for every woman. I think there are a lot of literature, and even men need vitamin D supplementation at least once a month, I feel. And in summarize, of course, the exact dose is not known. To definitely improve the maternal and neonatal outcome, we would recommend between 1,000 and 2,000 international units per day, along with calcium, to every pregnant woman. And definitely, we must take care of those patients who are in the high risk category, follow them, identify them, and treat them. And I'm sure I have tried to convey the role of vitamin D, pivotal role during pregnancy and lactation. Thanks for a patient hearing. Thank you.
Dr. Krishna Kumar, sir.
Thank you very much, sir. Sir, I just have in a nutshell, sir. Usually, sir, a vitamin D3 talk at 3:45 in the afternoon is a very nice recipe for, a good sleep. After first MBBS, what we have been on. But let me tell you, sir, right now we have about 812 people who have logged in. Plus, we have about 9 of us who are the speakers and the moderators. So hats off to you. You've made it a very nice talk. You've made it concise.
I was tense, as I told you, because I said I'm not prepared. Even today morning, I said, what am I going to talk? So I don't know whether I presented well.
But very fantastic presentation, and thanks for revisiting biochemistry, and it's stimulated some old cells.
As Subhash said, vitamin D3 in the afternoon is going to be really boring.
No, but it was very good. So my one question, what I want to know is, instead of doing the test for vitamin D, what is the harm of giving it empirically?
Correct. That is what I said. Now, routine screening is still not recommended. So definitely giving empirical is what we all follow. And that is where the dose which has been, there is a variation. People are worried whether if I give a higher dose, it will cause hypervitaminosis and a calcium problem and kidney.
So when you did research, did you see any papers on hypervitaminosis?
Yes, they did said above 4,000 the risk is high. Above 4,000 IU per day.
Okay.
So that is where the recommendation stops at 2,000.
But traditionally, the physicians, how they give is once every week for the first 2 months, and then once a month.
That during pregnancy, it is said that 60,000 IU per month is enough.
Okay.
60,000, which is otherwise weekly we give in PCOs who have proved vitamin D deficiency. We give for 12 weeks. But in pregnancy, it is mentioned, don't give it, because pregnancy, the calcium uptake is as such increased. That's a normal physiology.
Okay.
So you don't give beyond 60,000 IU per month.
Okay.
And dose is about 1,000 to 2,000.
And sir, for your infertility practice, do you give empirically to all this PCOS and all vitamin D, or you diagnose?
So as you rightly asked, because PCO patients we find very frequently, and there we test. And for PCO patient, we give them a 3-month course of vitamin D per weekly.
How you give that 60,000?
60,000, per week.
We can give a single dose of arachital also?
Yeah, we can give. Yes.
Krishna sir, the one question is there, that is how much, suppose if you stay in sunlight, what time you have to get exposed, and how long you have to get exposed?
Yes. Now it is roughly mentioned minimum 30 minutes between morning 9 to 11. The timing is also mentioned that roughly between morning 9 to 11, if you can expose your skin for 30 to 40 minutes, you get roughly 400 IU per day.
Okay.
But there is one catch in that. 80% of your skin should be exposed.
That's all. Your skin should be. I didn't come into that. And your skin should not be hyperpigmented.
Yeah.
All those things are there.
Sir, Krishna Kumar, sir. Hello.
Yeah, sir. Yes, Viru sir, please.
Yes, sir. Sir, it was a nice deliberation, sir. I am Dr. Virendra Kumar, working as professor in WIMS Bellary. My question is whether vitamin D should be called as a vitamin or it is a hormone.
Yeah, definitely. Looking at action, definitely it is an hormone. Yes.
So I think via media we can call it as vitamon. Okay, sir.
Vitamin D is a vitamin. The active form is a hormone. That is answer.
Okay. And regarding, no doubt, we Indians as well as the ancient Egyptians worshipped sun as God, who is the giver of vitamin D. Okay. And you name anything, it is there in the literature, starting from preeclampsia. It is also said that it is prevents cancer. So a lot of non-calcemic benefits are there as far as vitamin D is concerned, including prevention of preeclampsia, prevention of cesarean section, prevention of carcinogenesis, so many things. And suppose 60,000 units we are all using in practice. Sometimes patients, instead of taking weekly once, she may end up taking daily. And what is the harm?
You have to measure her vitamin D levels, because there can be hypervitaminosis and calcium can be increased. So that is one thing which you have to take care. Yes.
Okay.
So if you are going to give vitamin orally, is there any guideline that we have to take with a fatty meal or something? So that is a fat soluble vitamin.
Yeah, I have not come across, but it is recommended to be taken along with food.
Okay.
And that is all I have come across. Yeah.
Is there any difference between taking a softule and powder form? Vitamin
Liquid
D.
is available.
Liquid is also.
Liquid is available.
No, the literature doesn't say whether which form. I couldn't go into that, whether powder form or liquid form is better. I've really not gone into that.
And we have also gummies.
Gummies available.
No, even some small tissue paper like thing has come from a company where you just keep it. It melts.
Biofilm. The biofilm.
Biofilm.
Right.
So it is. We cannot
All
say.
said and done, I think we should. What is cheap for the patient? What is
what
good for the
is
patient?
definite.
Right. Okay.
Yes.
Right.
And sir, one last question. Is there any link between vitamin D deficiency and anemia?
I don't think I have come across vitamin
actually,
D. See
once,
others,
once I had delivered a lecture on this vitamin D.
Peronia D3 and all that.
Yeah, there is a correlation between iron deficiency and vitamin D. It is said that in erythropoietic tissue, vitamin D3 acts as a paracrine fashion for erythropoiesis. So that's why even if you supplement the vitamin D, the chance of anemia is less.
Correct. Good.
So there in erythropoietic tissue, it acts like a paracrine hormone.
Yeah, that is definitely a good input.
Okay, sir.
Sir, now you understand why I got Professor Virendra Kumar, sir.
That is what I said. That is what I said. As a student, I'll be learning a lot from the professors. Thank you.
Before we go to the next talk, sir, I would like to thank you from the bottom of my heart for this wonderful lecture and making it very, very interactive and very good. And a couple of announcements here I have to make that, we have people all over India right now who have logged in. I especially mentioned to a couple of my friends who have logged in from Bhopal, Manisha Khare madam. Then we have Varsha Lade from Nasik. And we have also my teacher, Suma from Mysore. But I would like to congratulate three of them who have first 3 persons to have logged in. One is Mr. Ramesh Kumar, Dr. Ramesh Kumar from Jaipur. Sir was the first person to log in. Dr. Yogendra from Dehradun and Dr. Elizabeth from Calicut. So I would like to thank them for logging in first. And also would like to thank certain people who are from the Northeast, Agartala, Amulya, Pradyut, Soresh and Epal, who also logged in from Agartala. And I think the crux of this is we have kept everybody, we have taken care of Kerala, we have taken care of Karnataka. And because of Viru sir and his proximity to Andhra, Chala Mandi Andhra nunchi vastunaru, Eluru, Rajahmundry, Kadapa, Ongolu, akkadi nunchi Chala Mandi vastunaru. Karnatakaದಿಂದ ತುಂಬಾ ಜನ ಬಂದಿದ್ದಾರೆ, ನಿಮ್ಮನ್ನ ಕೇಳ್ಕೊಂಡು ಬಹಳ ಜನ ಬಂದಿದ್ದಾರೆ. Thank you very much sir. And again मराठी तर काय बोलायचं सर, खूप लोक आलंय, नाशिक मधून आहे, मुंबई मधून आहे, नवी मुंबई मधून आहे, खूप लोक आलंय, चांगला.
Even Jabalpur.
It's all because of the Malaya.
So right now, sir, we have for the benefit of audience, we do have a lot of questions at the end of the session. Also, we have a little bit of time also after 5 also. So please do log in and ask your questions to Professor Chellamma, Professor Jyoti, and Krishna Kumar sir also. Now over to the next speaker. Now we have the next speaker, Dr. Chellamma madam, and I would like Viru sir to please introduce Chellamma madam.
Yeah, I have honor of introducing Professor Dr. Chellamma. She is MD, DGO, and FICOG. She is working as professor and head of the Department of Obstetrics Gynecology in Medical College, Calicut. Because
hello.
Chellamma madam?
Yes.
Yeah, we will just play your module right now, ma'am.
Okay. Am I audible?
Yeah, you're
yes,
yes, ma'am.
Yeah. So I have honor of introducing Dr. Chellamma. Over to you, madam. Hello?
Okay, okay, come here.
Yeah, can you hear me, madam? Hello?
Hello,
Yes, sir,
madam, it's over to you, madam.
can you see the slides?
No, slides
madam.
is not shared yet.
Yeah,
Slides shared.
Maruti? Hi,
Hello.
Hello. You have to
Hello?
click on the share screen button now.
Madam, share screen.
ma'am, there is just
Yes, yes, yes.
You open your PPT first.
PPT already open.
Madam, click on share screen.
Go to the
Green
Zoom,
button.
Zoom
The
first.
screen is not seen.
On corner top, you will find the screen, and you have to click on the green button over there. Arrow
Bhadra?
will be there.
Yes, yes. Bhadra.
in the meantime, when madam is doing, we'll have a couple of questions which are remaining actually for
Jyoti madam, yeah. We can take.
Jyoti madam.
Yeah.
Madam, one question is there, Dr. Jyoti madam.
Yeah.
Can you hear me?
Yes, yes, sure.
Yeah, if one of the sacs show hydatiform mole, how do you manage?
Actually, I have never had an experience, but I attended a webinar last week in which there was a twin pregnancy with one complete mole and another normal twin. So what they did was they, under ultrasound guidance, they evacuated the mole. And when they followed this pregnancy, they found that molar tissue was seen developing in the second twin also. So then they did karyotyping and then they had to terminate that pregnancy. So it is very rare. And there is one case presentation by Professor Shekran where it was a partial mole and he gave all the risk and pregnancy
Open your
continued.
presentation.
The pregnancy was continued till 32 weeks and then sir did a cesarean and got a baby with another partial, with the placenta showing partial mole. So these are the only two cases as what I know. If any of the other speakers have any experience, they can share.
Madam, Dr. Chellama has shared her PPT.
Okay.
Yeah, over to you, Chelama madam.
Yes, yes, I can hear. Are you audible?
Yes, ma'am.
Yes, ma'am.
Good afternoon, everybody, the moderators, the co-speakers, and the
Good afternoon,
viewers
madam.
from all over India who are viewing this presentation. Now, my topic is little different from that of the previous two topics. It's the commonest medical complication in pregnancy.
Just click on the next. And then you can press the next and previous button.
So this is an important cause of maternal morbidity and mortality, and the risk can be there in the antepartum period, intrapartum period, and the postpartum period. So it is a very, very high risk pregnancy, and also a close monitoring of the patient should be there with the cardiologist and also the obstetrician, especially the senior obstetrician. Another important thing is that the patient should be managed in a tertiary care center. So coming to the types of heart disease, we all know that there are congenital heart disease and acquired heart disease. And coming to the overall incidence is 1%, both congenital and acquired. Congenital heart disease again can be cyanotic and the acyanotic. Acquired, as we all know, that it is mostly the rheumatic heart disease and the cardiomyopathies and the ischemic heart disease. And the most common acquired disease, the rheumatic heart disease, where the mitral valves are affected more, and the mitral stenosis is the most common and dangerous one, and the mitral stenosis occurs in 3 to 4% of the patients with rheumatic heart disease. Now coming to the congenital, the structural causes are there, and most often nowadays we are seeing the patients with PDA, ASD, VSD, etc. are corrected in the childhood period itself, and they do well in pregnancy and later during the management of labor. And coming to the cyanotic heart disease, that is the Fallot tetralogy, Eisenmenger syndrome, which is very, very high risk, and 40% of maternal mortality is there, and there is high risk for the mother and the fetus. And the problems include worsening due to the cyanosis and the risk of IUGR for the baby, and also there may be the problems for the baby in the neonatal. Now coming to the valvular disease, the aortic stenosis complications arise due to the restricted capacity to increase the cardiac output. And the other valvular disease that I mentioned, the regenerative valves, artificial heart valves, and the mechanical heart valves.
Madam is interfering like this.
So coming to the non-valvular, that is a Marfan syndrome. Again, it is a dangerous condition, autosomal dominant condition with genetic counseling is essential in these cases. In this pregnancy, the condition carries very risk of aortic dissection and aneurysm, and also there is chance for rupture. And pregnancy is contraindicated in this type of patients, especially if the diameter is more than 4 to 4.5 centimeter. And coming to the dissection of the thoracic aorta, there is an increase in the maternal death due to the ruptured aneurysm and also to the thoracic aorta aneurysm, and where the mortality is very high. Now coming to the cardiomyopathy, it is another cause of maternal death. Unexpected cases most often occurs in patients who are not having any previous evidence of heart disease, and usually occurs in the late pregnancy up to 5 months postpartum. Now coming to the coarctation of aorta, the most recent was surgically corrected again already, and even though it is corrected, there may be some residual narrowing, and there may be problem occurs due to the aneurysm formation. Now coming to the dysarrhythmia, sudden arrhythmic death syndrome, that is SADS, is a sudden unexpected cause of maternal death due to cardiac failure, and myocardial infarction, ischemic heart disease, etc. also can occur. Now coming to the hemodynamic changes in pregnancy, all we know that you as teachers, we usually ask in the examination to the students and both undergraduate and the postgraduate students, there is a physiological changes in pregnancy which occurs in the cardiovascular system. So the first one is the circulatory changes start in the early pregnancy and reach the peak level towards the end of the second trimester. And the plasma volume also increases by 40 to 50%. Increase in the stroke volume, cardiac output increased by 50% up to 32 weeks, then becoming a plateau. And it may again increase in the labor and the postpartum period. That is why the problems occurs in the intrapartum and postpartum period. And red cell mass RBC count increases by 20%, so there is a chance of physiological anemia. Heart rate increases, ectopic beats occurs, diastolic pressure decreases, and a widening of pulse pressure during pregnancy, and oxygen consumption also increases. Now this chart shows the graph shows the increase in the cardiac output, the blood volume, and the heart rate, etc. From the first trimester, second trimester, and the third trimester. And we know that it is coming to the third trimester, and again it is in the postpartum period, and after 6 months it comes to normal. Now, anatomical changes, we know that the displacement of the heart because of the enlarged ground uterus and the rotation of the heart occurs, and the upper beat may be felt in the fourth left intercostal space lateral to the midclavicular line, and straightening of the cardiac border may be there and shows the impression that there is the cardiac enlargement. S1 may be loud, even third heart sound may be there, systolic murmur there may be there, ECG changes may be there. So all these changes can occur in the normal pregnancy. So as obstetricians, we have to differentiate between the normal changes and the abnormal changes during the pregnancy. Now, what happens in labor? During labor also heart rate increases, BP increases, cardiac output increases by 30 to 60% during contractions, oxygen consumption increases, again cardiac output increases in the postpartum period. That is why the problems occurs mainly in the immediate postpartum period, and additional 500 ml of blood enters into the circulation, and changes may come back to normal after 2 to 3 weeks of postpartum period. And again, this chart shows the changes in the blood volume, heart rate, cardiac output, blood pressure, stroke volume, etc. in pregnancy, normal pregnancy, changes during labor, and changes during in the postpartum period. All this increase in the during labor, and it changes come back to almost normal after delivery. So we all are familiar with the NYHA classification of heart disease. Class 1, there is patient is having heart disease, but there is no limitation of physical activity. Class 2, there is slight limitation of activity. She can do ordinary works. And 3, there is marked limitation of physical activity, and she may be asymptomatic at rest. And the class 4, that is even at rest, she is symptomatic and can have problems of discomfort, etc. So this is the new classification, the modified WHO classification. This is very important in showing the risks of the heart disease. WHO class 1, class 2, and 3 and 4. And class 3 and 4, it is very, the patient may be having increased heart disease, especially it occurs in the hypertensive disorders, that is Eisenmenger's stroke syndrome, etc., especially in type 4, etc. This is another risk assessment method. So coming to the symptoms in heart disease, or we are familiar with the symptoms, especially when the patient is having rheumatic heart disease and the mitral stenosis, etc., coming to our antenatal clinics. So the patient can have breathlessness, dyspnea, palpitation, even syncopal attacks may be the pulmonary edema features like orthopnea, paroxysmal nocturnal dyspnea, chest pain, and hemoptysis may be the in pulmonary embolism, etc. So even though the patients have no features, but when the patient comes with symptoms like this, patient should be referred to a cardiologist, and echo should be done, and diagnosis should be done, or to have to rule out any problems, any structural heart disease. Now coming to the signs of heart disease, we know, especially in cyanotic heart disease, patient may be having cyanosis, clubbing and raised AVP, diastolic murmur may be there, grade 3 systolic murmur with thrill, atrial fibrillation, and also in mitral stenosis, the typical features of tapping excess mid-diastolic murmur, and the basal crepitation and the lung, in the lungs may be there. So this is the murmur, even though they are seen in the physiological murmur may be there. So you have to find that it is pathological when there is a grade 3 murmur or murmur with associated with thrill, and along with the atrial fibrillation, features of atrial fibrillation. Now coming to the diagnosis of heart disease in pregnancy, the most important thing is you have to take a detailed history. So from the history itself, we can come to a diagnosis of the previous heart disease or in the childhood disease, or whether it was present in the previous pregnancy, especially in the multiparous patient, etc. And of course, you have to do a complete physical examination of the cardiovascular system. And X-ray shows the straightening of flat border of the heart, and also enlarged heart, and also there is the prominent lung markings. And the most important method of diagnosis is the electrocardiography, and it is very useful in diagnosis of arrhythmia. But there can be ECG changes like ST wave changes or Q wave or inverted T wave changes, etc. But the most important method is the echocardiogram, but ECG is still there, especially to rule out arrhythmia of the arrhythmia. So this is the X-ray showing the enlargement of the heart, and also you can see the curly B lines in the X-ray, and also the ECG showing the features of changes in the mitral stenosis. Now, diagnosis of heart disease, as I mentioned earlier, electrocardiography, that is the best and ideal method nowadays because it is non-invasive and it is safe in pregnancy. It can be done either transthoracic or transesophageal route, and also this structural anomaly also can be diagnosed, and valve area, especially in the stenotic valves, valve area can be diagnosed accurately, and depending upon the valve area, you can say whether it is mild, moderate, or severe. If the valve area is less than 1 centimeter square, that means it is severe, and the patient can have problems during labor or in the antenatal period. And diagnosis of heart disease, the exercise testing is also mentioned in textbooks, because especially in congenital heart disease and valvular disease, and that is one method started from earlier itself. And computer tomography, it is not usually done, but it is very diagnostic in case of pulmonary embolism. And MRI is again advised only if there is no proper diagnosis method by either methods. And cardiac catheterization, it is not usually done, but it may be necessary for the interventional procedures during pregnancy. Now, the most important aspect of the heart disease management of heart disease is, especially congenital or cyanotic heart disease, the pre-pregnancy counseling. And patients with following conditions need referral, and preferably they should be counseled before they become pregnant. Especially the conditions like artificial valves or symptomatic stenotic valvular disease or congenital heart disease, corrected or uncorrected, cyanotic heart disease and Eisenmenger syndrome, pulmonary hypertension, previous peripartum cardiomyopathy, and severe hypertension or symptomatic IHD. So the pre-pregnancy counseling is very, very important. Several aspects of the pregnancy should be discussed, and it should be done by the cardiologist. All women with non-cardiac disease should have become pregnant, and there should be having pre-pregnancy counseling. So we should discuss about the current fitness for the pregnancy, fertility and miscarriage rates, and the maternal risk and outcome, expected fetal complications, plans for delivery care and the pregnancy and delivery, long-term prognosis and risk of occurrence of congenital disease for the fetus, and surgical corrections of the disease before pregnancy. So all these aspects should be discussed in the pre-pregnancy counseling. So pre-pregnancy counseling, again, this is very important because the WHO risk score is very important to see, to counsel regarding with that. Specific risk should be informed, and according to the modified WHO classification risk assessment, and also there is a fertility treatment is contraindicated, especially in WHO classified 4, especially Eisenmenger syndrome, etc. And in this chart, we can see that the class 4 extremely high mortality is there, and also the morbidity and mortality. So genetic counseling is also important. Risk of transmission of hereditary heart disease to the offspring, and autosomal inheritance may be there in Marfan syndrome or hypertrophic cardiomyopathy. So genetic counseling is also important. Now, how to assess the risk assessment in heart disease? And the most important one is the WHO modified WHO risk I mentioned. The other scores are Carpret risk score and the Sahara risk score. I'll come to that. So this Carpret risk score, that is the depending upon the prior cardiac status, the NYHA classification, arrhythmia, valvular conditions, and also myocardial dysfunction, all is having 1 point each. And if more than 1 point, 75% chance of mortality is there. That is the Carpret risk score. And the next is the Sahara risk score. Again, the predictors are the previous arrhythmia, then the cardiac problems, systemic AV valve regurgitation, etc. Again, this important is that here we can assess the risk of the mother and also the risk of the fetus, where chance of congenital anomaly is there. So there is, if there is risk is there is 70% chance of fetal involvement is there in case of the risk score is more than 3.51. So this Sahara risk score, as I mentioned in this chart, on one side we can see the risk on the maternal side, and the other side we can see the offspring risk. That is, if the point is more than 1.5, there is a very high risk of transferring the disease to the fetus. That is offspring. That is 60% chance of the disease for the fetus. Now, coming to the maternal complications, we have already, many of us have come in this condition during our practice, congestive cardiac failure. So the anemia, hypertension, hyperthyroidism, multiple pregnancy, etc., increase the risk of cardiac failure during pregnancy. So in this case, you have to control the anemia or control the hypertension, etc. The other complications are acute pulmonary edema, arrhythmia, bacterial endocarditis, and mortality during postpartum period mainly. So the fetal complications, again, the chance of abortions may be there, especially in cyanotic heart disease, congenital malformation due to the chronic hypoxia, and maybe due to the teratogenic drugs used for the management. IUGR may be there, and congenital heart disease in 5% of babies, and neonatal anemia and hypoxia may be there. Now, risk of obstetric and the offspring complications, the obstetric complications, especially premature labor, preeclampsia, anemia, and the postpartum hemorrhage, and the offspring, as I mentioned, there is 18 to 30% patients with heart disease have complications, and neonatal morbidity is also about 1 to 4%. Now, fetal assessment, how to assess the heart disease for the fetus. That is as Dr. Jyoti has already mentioned about the new NT. Here we have to do a nuchal translucency scan at 12 weeks of gestation to screen the chromosomal anomalies, and also you can identify some of the fetal congenital heart disease. And all women with congenital heart disease should have a fetal echocardiography at 19 to 22 weeks of pregnancy, and 45% of all congenital heart disease can be identified by doing the echocardiogram, fetal echocardiogram in the second trimester. Now, what about the intervention in the mother during pregnancy? And even if intervention is needed, it should be done in the second trimester, most probably at 4th month of pregnancy. And the cardiac surgery is recommended only when the medical therapies fail, or all the patient can recurrent pulmonary edema, etc. So the best period is to do the procedure is in the second trimester. So what cardiac procedures we are doing nowadays? We are doing balloon valvuloplasty. Ideal time in the second trimester I mentioned. So the indications are failure of medical management in intractable cardiac failure, or recurrent episodes of pulmonary edema and hemoptysis. So, and coming to the antenatal management, it's very, very important, because we have to pick up the disease in the at the previous, just before pregnancy by pre-pregnancy counseling, and if it is found to have heart disease, the proper antenatal management should be there. So, the most important thing is patient should be managed only in a tertiary care center. So, the cardiologist and obstetrician together takes the management, depends on the class of the disease, and also you have to advise regarding the diet, rest, iron, calcium, and vitamins. Sarah has already mentioned about the vitamin D, and the correction of anemia and the early detection of preeclampsia is very, very important, because it may increase the risk of complications. So it should be treated or corrected before delivery. So antenatal management, again, the most important thing is usually many of the patients come with dental, for the dental extraction, it should be done under cover of antibiotics. Any infection should be treated, especially the urinary infection, and vigilant watch for cardiac failure, ultrasound evaluation of the fetus. And when will you admit the patient? Class 1 and 2, and the patient should be seen every month if there is not much problem, and they should be admitted. The class 1 and 2 should be admitted at least by 36 weeks, and 3 and 4 should be admitted whenever it is diagnosed. That is, means from the early pregnancy itself, there should be in the hospital for management, because they can develop cardiac failure during the antepartum period. So coming to the fetal assessment, as already mentioned, the NT and also the anomaly scan and the fetal echo, and also in the third trimester, there should be physical profile and CTG, and also NST, etc. should be done. Now, coming to the timing of delivery, when will you allow the patient to deliver? And many of the patients may get into spontaneous labor. That's our experience. But if the patient is not getting into labor by 40 weeks, according to the latest guidance, induction should be done, because you can avoid the cesarean section. We know that the cesarean section is dangerous for vaginal, heart disease. So timing of induction will depend upon the cardiac status, the cervical finding, and the fetal condition, and also the fetal lung maturity. So labor induction, what are the drugs which can be used? Both misoprostol and lansoprazole can be used safely to induce labor. PG1 and PG2 have the theoretical risk of coronary vasospasm, but there is low risk of arrhythmia. Dinoprostol has profound effect on blood pressure than PGE1, so it is contraindicated in cardiovascular disease. Mechanical methods also can be used, and ARM, infusion of oxytocin, can be done. But the thing is that early ARM should be avoided, and don't allow the patient to go for a prolonged induction delivery in time. Now, which is best for vaginal delivery? Always from our seniors or the books or experience, we know that vaginal delivery is best for heart disease complicating pregnancy because it is associated with less blood loss, low risk of infection, low risk of venous thrombolism, and also the pulmonary embolism. But there are certain indications for cesarean section, the mainly obstetric indications. And the non-obstetric indications are that's the Marfan syndrome, Eisenmenger syndrome, even though they have become pregnant. But if they become pregnant in very high risk cases, it should be better to terminate the pregnancy. But some patients want to continue the pregnancy. In these cases, they can do elective cesarean section. And in patients, they should be done in patients who are on oral anticoagulant drugs. So what about the delivery in anticoagulated women, where the patient is taking heparin or warfarin, etc. So for a planned cesarean section, therapeutic low molecular weight heparin should be omitted 24 hours prior to surgery. In very high risk women, therapeutic heparin can be restarted after 6 hours of delivery. And women with moderate or low risk, single prophylactic dose can be given. That is, if the patient is less than 50 kg, 20 milligram, and if it is patient is 50 to 90, 40 milligram per kg is given, and also 40 milligram is given. And with raised BMI, 0.5 milligram per kg can be given 6 hours after delivery, after cesarean section. That's about the anticoagulant. And also where the patients are on prosthetic valve. Here the problem of thromboembolism and infective endocarditis is the anticoagulation in pregnancy. The heparin is safe during pregnancy, that is either low molecular heparin or unfractionated heparin. Warfarin in first trimesters should not be given because it can produce congenital anomalies, that is a warfarin embryopathy. The current recommendation is change to heparin at 6 weeks, IV or subcutaneous, restart warfarin at 12 weeks, switch over to heparin again at 34 to 36 weeks, stop heparin 6 hours before delivery, restart heparin 6 hours after vaginal delivery or CS in 12 hours, and restart warfarin after 3 days of delivery. And the most important thing is they should be monitored BPT and INR. So infective endocarditis prophylaxis, again, it is a very controversial area, but nowadays so many changes have come. They just needed in prosthetic cardiac valve, previous history of infective endocarditis, and the unrepaired cyanotic heart disease, or also the residual defects, the corrected diseases with residual defects. And in most cases, corrected cases or in ordinary PDA or MVP, etc., prophylaxis is not needed. So antibiotic prophylaxis is recommended regime for cesarean section or other obstetric procedures, presence of suspected sepsis and structural condition. That is the 2018 ESC guidelines says that it is IV clomoxiclav 1.2 gram plus gentamicin 5 milligram per kg at induction of the anesthetic. And if BMI more than 30, and amoxicillin IV 1 gram also. So that is the one guideline. But the concept of antibiotic prophylaxis to prevent infective endocarditis prophylaxis had changed considerably from the 2006 American Heart Association. And again, the current guideline again says dose and administration regimens have become simpler nowadays. Amoxicillin 2 gram, 30 to 60 minutes orally before procedure. Clindamycin 600 milligram, 32 minutes orally before the procedure if penicillin is sensitive. Virtually all guidelines committees says that the antibiotics are not routinely recommended and only in cases who are undergoing the invasive dental procedures. In this case, only antibiotics are needed. So coming to the emergency management, if the patient develops cardiac failure, there should be every facility to manage the patient, and oxygen, pulse oximeter trucks, emergency trucks, and facility to transfer to theater or ventilator if needed. All the facilities should be there. That's why I told you earlier, this management should be done only in a tertiary care center where all the specialists and facilities are there. Now coming to the management of labor, first stage, the proper intrapartum caring is very, very important, and there is high chance of cardiac failure. So the anesthesia is morphine, is added nowadays, epidural is given because it can be continued for the second stage of labor, and fluid management, the most important thing, don't give more fluid, because the chance of pulmonary edema is the restrict fluid to 75 ml per hour. And position the left lateral or proper position, antibiotics as I mentioned earlier, and monitoring of the patient pulse, BP, heart rate, the pulse oximeter exam with the pulse oximeter and chest exam, and watch for the uterine contraction, progress of labor, pathogram should be the fetal monitoring, continuous CTG should be the, and the availability of the team for the management, that is senior obstetrician, pediatrician, anesthesiologist, and the cardiologist. Now, this is the pathogram which shows the, it is very important in the management of any patient, but in heart disease, which is a high-risk case, the pathogram monitoring of the labor should be done by the pathogram. So second stage, when usually there may not be much problem during labor, especially in cyanotic heart disease, the baby may be small or IUGR may be there. Usually the labor progresses very well. And if when there is second stage, the 40 milligram lasis is given just before delivery IV, assisted the delivery can be cut short by forceps or vacuum to reduce the maternal effort. Forceps is better, and continuous fetal monitoring should be there even in the second stage of labor till the patient delivers. Now coming to the third stage, most important, no methotrexate should be given. Active management of third stage should be given. Misoprostol 600 to 1000 milligram can be used for management of PPH, but avoid PGF2 alpha because there is chance for the spasm. So proper monitoring immediately after delivery to rule out cardiac failure. Puparium also, the patient should be monitored well for 24 hours, and the early ambulation should be there to avoid, and also to avoid thromboembolism. Now, postpartum period is associated with significant hemodynamic changes, as I mentioned earlier, fluid shifts, etc. So they should be properly managed because many of the cardiac failure and maternal death occurs during this period. So the patient can have precipitate cardiac failure, hemodynamic changes may be changing, and thromboprophylaxis should be given in the postpartum period. Now, coming to the contraception, and the ethinyl estradiol containing contraceptives have the greatest chance of risk of embolism, should not be used. Progesterone only contraceptives can be given, and oral desogestrel nowadays is used in many cases. It inhibits ovulation, and it is useful in cases where the patient was having PCOD. And barrier methods are not reliable because, but it may prevent PID. But it is ideal ideal methods are coming. So copper devices can be given in non-cyanotic and uncomplicated valvular disease. Low dose OC pills can be given in selected cases. And LNG IUD is another safer option of contraception in cases of heart disease complicating pregnancy. Now, coming to the emergency contraception in heart patients, copper intrauterine device is another effective method, but can be continued as ongoing contraception. Alternatively, 1.5 single dose of levonorgestrel can be given within 72 hours of unprotected sex, but there is no evidence of increased rates of thrombosis. Now, coming to the sterilization, it can be done by tubal ligation if the pregnancy is contraindicated or the family is complete, and usually vasectomy is an effective option, the main sterilization. Now, another important situation where I mentioned earlier, because some patients may die immediately after delivery with no previous maternal history of cardiac disease. So it is called peripartum cardiomyopathy. So seen in previously healthy woman, clinical features of cardiac failure may be there, occurs in the last 5 weeks of pregnancy and postpartum 5 weeks. And predisposing factors are mainly preeclampsia, multiple pregnancy, multiparity, smoking, diabetes, preeclampsia, and also there is the advanced stage and teenage pregnancy. Patients frequently present with acute heart failure, but also with ventricular arrhythmias or even cardiac arrest. So types of cardiomyopathy, especially for the postgraduates, that is 4 types are described. Dilated cardiomyopathy, and in this case, usually the dilatation of left ventricle and dysfunction occurs, and the 50% of cases it may be idiopathic. And the another one is a hypertrophic cardiomyopathy. It is usually autosomal dominant, and this cases usually the pregnancy is well tolerated. The others are restrictive cardiomyopathy and arrhythmiogenic right ventricular dysarrhythmia. So diagnosis and management, it is on few more sides. And echocardiography is for the diagnosis of that is a cardiomyopathy. And echo evidence shows the left ventricular failure. Management includes the treatment of cardiac failure, including ACE inhibitors following delivery. Prophylactic anticoagulation should be given, and maternal mortality may be as high as 50% in severe cases and with acute presentation. Now, coming to the prognosis, it depends upon the type of heart disease, NYHA classification, the modified WHO risk for arrhythmias, associated complications, etc. And also fetal complications are there, the IUGR prematurity and risk of congenital heart disease, and IUGR prematurity, etc. The prognosis is poor in young age. Now, management of cardiac failure in pregnancy is usually done with the help of our colleagues. Monitor oxygen, they provide non-invasive positive pressure ventilation, diuretics, the emergency drugs should be used, diuretics, ACE inhibitors, beta blockers, digoxin, and anticoagulants should be used for the management of cardiac failure. Two more slides. Zooming complete. So, so causes of maternal death, pulmonary embolism, pulmonary edema, arrhythmia, cardiac failure, rupture of aneurysm, and cardiac failure. So the take-home message is that heart disease complicated pregnancy is an important medical cause of maternal morbidity and mortality. Congenital heart disease is more often encountered than occurred because, and usually it is corrected, but the risks are low when it is corrected. Pre-pregnancy counseling and genetic counseling should be advised for congenital heart disease. They should be managed by a multidisciplinary team in a specialized centers. And these are my references. These are the latest references. There's a lot of matters there. That is the 2018 ES guidelines and the RCOG guidelines, NHS guidelines, and the newest one is the 2019 ACOG guidelines. I have taken many of the matters from these guidelines. And thank you very much.
Madam, thank you very much for that exhaustive talk. It was a wonderful one, ma'am. Very much. A lot of questions are there. And I have that, we have had a lot of talk about this hyper webinarosis and a lot of, talks and all, made fun of. Now, how is this for a webinar now? Now, this has been just by a doctor who has just logged in. He happens to be a doctor from Calicut. His 3-month-old child.
Joint secretary.
Yeah, he's the joint secretary of Calicut.
Joint secretary.
Rajesh. And I'm very happy to, for all the fun that is made of
not...
At this given point of time, we have 887 people who have joined in for this webinar. And it's a wonderful one. Had it been, a 2A1, then I could have had an exam here because we have Prema Dikuna madam also from Bangalore. We have Jairam Nambiar from Manipal. We have Vinendran sir. So a lot of your co-examiners are also there. And also your teachers, Shekaran sir, everybody over here. And I think it's been wonderful to have all three of you as very good speakers. And before I give the next job for the moderators, again, I would like to thank all the three moderators who have pitched in, had put in their hard work, have put in a lot of time for this. Dr. Virendra Kumar sir is a very good friend of mine and is a professor at BIMS Ballari. Thank you very much, sir, for moderating this session.
Thank you, sir. Thank you, Subhash.
Thank you, Mohan, and again, a good friend from Trivandrum Medical College. Sir has been a good teacher and a mentor to me always. And thank you very much, sir. And also to Dr. Samit.
Thank you.
Pradhan, the afternoon doesn't become, that really cheerful as sir is there. Sir makes any sort of, atmosphere is charged up when sir is around. Okay. And on behalf of Calicut Society, I would like to, and on my present behalf, Dr. Jyoti Chandran and my treasurer, Dr. Shekaran, and all the office bearers of Calicut Society, we would like to thank Torrent for giving us an opportunity for this wonderful talk. And also would like to thank all the delegates who have joined in all over India as I speak, we have 883 right now over here, plus the 9 speakers.
How much?
883. Very nice.
Thank you.
Number.
Speakers. So thank
All
you
talks were fantastic.
We are not closing it. We are not closing it. We are not closing it. We are taking all the questions till our moderators or the torrent teams.
The speakers are exhausted.
So right now, so we will give over to Dr. Reggie, Dr. Virendra Kumar sir, and Samir sir for the question answer session, sir.
Chellama madam, it was a wonderful presentation.
It was very exhaustive, but I made it very small because it is very long.
Yeah, I know.
Great, madam. Like people like us who have in private practice for last 20 years, it was like going back to medical college and getting the whole thing revised.
Yeah.
It was really very nice.
The good thing was madam mentioned about predators of cardiac events like Carpreg score. Because in medical colleges, we talk only about NYHA score.
NYHA classification.
Actually, if you see, NYHA score is useless because it does not say anything.
Useless.
So that's why.
But it is also included in the score also.
That's why a prediction of a cardiac event if any patient of cardiac disease comes to us is very important.
Madam, one question, like a person like us in private practice, we have a delivery and the patient then complains of breathlessness. So the idiopathic cardiomyopathy is one of the most dangerous diagnoses according to your whole thing. So how does a general practitioner go about it? Like what should be our protocol of managing? It has no heart disease beforehand, but she just has an idiopathic cardiomyopathy postpartum.
So if there is no previous heart disease or the patient is not having any symptoms and the patient comes with cardiac failure, you have to think of the possibility of cardiomyopathy.
Right.
So echo should be done immediately. So by echo, echo shows the only diagnostic method of
but the management before the echo is done, like what we should we give Lasix 100 milligrams?
Cardiac failure along with start managing the cardiac failure along with the cardiologist. By the time the echo comes, then you go change the management with anticoagulation, antibiotics, etc. The treatment is only features management of cardiac failure.
Yes. Hello.
Yes.
Hello, madam. Hello, madam. Actually, sir has asked how to manage cardiac failure in pregnancy. That I think you have well explained in your slide. Hello.
Sir has also asked the same question. Management of failure in labor.
There was one slide.
That was a slide.
Yeah. Any change in the IE prophylaxis according to the ESC 2018 guidelines of cardiology? Is there any change in the infective endocarditis prophylaxis management?
I think madam showed, no?
There is no place for infective endocarditis prophylaxis in simple cases. Only if there is high-risk cases where the patient goes for dental extraction, etc. Otherwise, there is no place. There's the 2006 guidelines, American Heart Association says that a lot of complications, ampicillin, gentamicin, etc. Nowadays, it is simple dosage. That is the latest advance in the management of infective endocarditis. That is a clindamycin, especially if the patient is sensitive to ampicillin or amoxicillin or clindamycin. So they say it is only single doses. Even for cesarean section, they are not advising prophylactic antibiotics.
So can we take home a message that we can just give clindamycin for all heart disease patients instead of keeping ampicillin?
Even though textbooks or guidelines say that, I don't know how
it's very easy to give, no? 600 milligrams.
How the practitioner, I know many of the practitioners
are still
using ampicillin and gentamicin combination still nowadays.
Yeah. Using clindamycin will increase the resistance, so better to go for the standard moxiclav combination or ampicillin gentamicin combination, because clindamycin is a second or third line drug. So always go as a second or third line. Don't never use clindamycin and vancomycin as first line drugs.
That is a single dosage in simple cases.
Okay.
In
American Heart Association, for any simple valvular lesions, it did not advocate infective endocarditis prophylaxis.
That's why I mentioned that.
Yeah. So, however, British Society of Antimicrobial Prophylaxis, they advocate aortic bicuspid valve. If it is there, you give infective endocarditis or any aortic abnormalities. If the patient has aortic regurgitation, so that is the one change, which is they don't agree with the American Heart Association. So in India, what happens? Irrespective of the American Heart Association, they don't want to take a chance. Even for simple valvular reasons, they give infective endocarditis prophylaxis.
That's why many of the practitioners are giving antibiotics, even though the guidelines are there. So
Yes.
still people are, I know some people are giving even antibiotics with ampicillin and gentamicin, the good earlier method.
Yeah.
But the practical purpose, I don't know. That is why I expected a lot of discussion here, especially regarding the antibiotic prophylaxis, because there is no consensus of opinion still now.
Madam, one more entity is there. Nowadays, we are coming across hypertensive heart disease, especially in severe preeclampsia patients. Even in primary, I have a patient, I have a postgraduate who is doing thesis on 2D echocardiography in severe preeclampsia. And you will be surprised to know that many of primary gravida have hypertrophied left ventricular mass. So Canadian Association, they say that preeclampsia is actually heart disease. It's a case of latent heart.
That is a combination, actually, they say.
Yeah. So
hypertensive cardiac disease.
This entity should be kept in mind. Hypertensive heart disease, which is sometimes wrongly labeled as a case of cardiomyopathy. Whereas we don't expect left ventricular function to return in cardiomyopathy, whereas in hypertensive heart disease, most of the times the left ventricular function returns back. So that is the difference between routine cardiomyopathy.
That is a new entity. That is a hypertensive cardiac disease.
HHD, hypertensive heart disease.
Yes.
Okay.
Another question is, if we use Moxiclav, that is Augmentin, because we never used to give this thing Augmentin to the antenatal mothers. So in this ESC 2018 guidelines, I think you have told about Moxiclav combination. So is there any harm?
Augmentin can cause a necrotizing enterocolitis in the fetus, so it is not to be given.
For preterm only. It is only for the preterm.
Yeah. Before the next question, I have a couple of announcements again. Thing is that we have the link of the whole webinar. Actually, I have a lot of questions here asking for the link of the webinar. We have all your email IDs on behalf of Torrent. I would talk to Torrent guys and also with our society. And what we'll do is we'll send you the webinar links to all the people, all the 893 who have logged in. We'll send you the webinar link so that it will be useful for you to whenever you're free to see this. And second is right. Anything else? Yeah. That's one thing. And about the since this is an ICOG accredited webinar, we have 2 ICOG points for this particular webinar. So we'll get all the certificates for you in all your email and sent to you on your email IDs. So give us about 3 to 4 days time after the signature of our president, secretary, the ICOG president, secretary. We will send all the certificates to your email in the next 3 to 4 working days. So kindly bear with us for about 3 to 4 days. And to other some questions saying that, whether we would like to know any webinar which is conducted by Calicut Society, we will see to that we'll send you all the links at an earlier date, so that you can join us. And we plan to take a few more of these educative webinars, more so in terms of the basics, in terms of students and exam going teachers, and also for the practitioners who wouldn't have otherwise got a time for their basics, because it's a busy practice. So at least to help them out, we will also have 2 more webinars also. And Jairam, as usual, has said any take-home messages are not required since we are all sitting at home. So sir always, has his own inputs. Thank you, sir. Thank you for this wonderful one. Yeah, over to you, sir, and Samir, sir, for other questions.
Yeah, one question to Jyoti, madam. There's one question from the audience. What will be the mode of termination of the dead fetus in monochorionic twin pregnancy if there is a placenta previa covering the internal os, partial or complete, and what's the best time to do so?
This is a tricky question. Both fetuses are dead or one is dead? Both fetuses are dead, then
if I assume if one is dead, then we continue pregnancy, right? And you do the MRI.
Yeah.
And then do a section at term.
Both are dead and it's a placenta previa, and if she's not bleeding, at least we can wait and see when this get compressed and the vessels vascularity decreases. There have been instances where
Dr. Manorama Jain has put this question.
Okay, if the first fetus is dead, then it may be difficult. Like if it's a placenta previa, definitely delivery may be difficult. But if the fetus dies and the placenta collapses and there is some chance for a vaginal delivery, otherwise you have to go for a surgical plan.
Yeah, Dr. Jyoti, madam.
Yes.
There is a question from Dr. Sneha. She asks, if a patient misses NT scan, how to determine chorionicity?
As I told in one of the slides, the detection rate falls to about 60 to 70% in second trimester, even 60% in third trimester. So
usually
consider them as monochorionics.
Usually this question is asked by Jyoti madam to the PG students, but this time it is the other way around.
Madam,
Consider them as monochorionic and manage unless you can see two different placentas sitting on both sides.
Madam, there is a question from Dr. Kishore Rajurkar. He's a senior professor from Delhi. He advises, instead of discussing contraception for a heart disease in a female who has suffered enough, her husband should be vasectomized.
Absolutely true, sir. Absolutely true.
Dr. Chellama, madam, one question. Role of cabergoline in postpartum cardiomyopathy.
Role of
cabergoline.
That is a PGF2 alpha.
No. Cabergoline. Not
Carboprost.
Cabergoline.
In heart disease.
Postpartum cardiomyopathy.
Postpartum cardiomyopathy, the patient is already in failure. I don't know the dose of use of the cabergoline.
Ma'am, nowadays cardiologists are using bromocriptine and cabergoline in cases of postpartum cardiomyopathy. It has got good prognosis.
I don't know.
What is the rationale? What is the significance? Same like to prevent in OHSS?
No, it breaks down the molecule. Something like that is there, but cardiologists are using. There is some theory is there for using cabergoline, and it has got a good prognosis. So many papers have come in recent time.
Yeah, there is one more clarification. I think there is a question about the twins, with twin mole with 1 mole and 1 normal fetus. I think that has been answered by Shekaran sir. He said that twin pregnancy with 1 mole and 1 normal fetus is confirmed by karyotyping, is allowed to term and delivered normally in our series. So there is no place for continuing pregnancy in a partial mole. If it's a complete mole, you do a karyotyping, and if it's a normal fetus, then you allow it to term. That's what sir has said. And one more question which sir has asked is auscultation for evidence of cardiac lesion in all pregnant women.
Should be done.
Yes. Okay, ma'am.
Routine cardiovascular systemic examination of the patient already mentioned. The auscultation of the heart is a must in the antenatal period.
A lot of doctors who have said that vasectomy should be encouraged too. Vasectomy should be encouraged for all men. I think that's a very good point.
Vasectomy already I mentioned.
Yeah, madam has mentioned that.
True.
But one comment by Dr. Nambiar, they has mentioned that co-amoxiclav is not advised in pregnancy. Dr. Jayaraman Nambiar, co-amoxiclav is not advised in pregnancy. So what is the opinion of the house in that regards? Co-amoxiclav, augmentin.
Yeah, augmentin.
It is advised.
So what is the take home? If it is not preterm, we can give as a prophylaxis.
Yes, augmentin usually give.
So what is the preterm? Up to 30, before 35, after 35 weeks it can be given, or after 37 weeks it can be given.
It's the augmentin.
Yeah.
Augmentin can be given in the antenatal period, but it's only in preterm babies it produces. Already there is chance of necrotizing enterocolitis, but in preterm, if you are giving, there is an increased chance.
Ma'am, there is one more question from our senior professor Sridevi madam. Dissection of aorta diagnosed in pregnancy, ma'am.
Echo and MRI.
Okay, ma'am. Okay. And more time, Viru sir, any questions?
Sridevi madam is the better person to answer that question because cardiologist in the house.
Madam, there is Chellama madam.
Oh.
Dr. Abhinaya Devi. Her question is primary pulmonary hypertension when to be terminated.
So pulmonary primary hypertension is actually a contraindication for pregnancy.
Yes.
And if the pregnancy occurs, ideally it should be terminated. MTP medical termination should be done because it is very, very high risk pregnancy. But somehow it may follow up to 34 weeks, which should be terminated when after giving.
Jyoti madam, one question. How are the double and quadruple marker measurements different from singleton pregnancy?
For multiple pregnancy.
Yeah,
actually the levels may be higher, so they are not that specific for multiple pregnancy.
Okay.
Yeah, sir, just last one small bit, sir, is that for all the benefit of all the audience here, we have a very good webinar tomorrow morning at 11 to 1 p.m. on surgical management of fibroids. where we have three very great speakers. We have Dr. Kurian Joseph from Chennai. We have Dr. B. Ramesh from Bangalore and Dr. Rajendra Sanpal sir from Mumbai. We'll be talking about the surgical management. It's not basically about surgical management. It is a decision making in the management of fibroids. Again, in an association with Calicut Society, where Professor Jyoti Chandran, myself, and we have two other good moderators like we had today, Dr. Bhavin Bhayani from Mumbai and Dr. From Manish Pandya from Gujarat. So do join us for that also. This is just, I just want, because before all of you log out, I would just like to tell you. And frankly, we have 899 right now. At 5 p.m., we have 899 people here. Hats off to you, all the delegates. Thank you very much for joining us.
Hats off to Subhash Mallya. You have made it possible.
Lila, sir, never. It is all your PG students and your friends, sir, from Ballari, from Mumbai, and all over India, and also Raji Mohan sir's PGs who have all joined. Thank you very much, sir. Right, over to the next question, sir. Viru, sir, over to you.
Yeah.
To Jyoti madam, one question has come as management of a single fetal demise occurring at 26 to 30 weeks. Jyoti madam.
Yeah, they say that before viability, that means maybe before 26 weeks, if fetal demise has occurred,
No,
the chance for
after 26
a
weeks.
life it occurs before, then you can just follow up the
26 weeks.
After 26 weeks, you can follow up the pregnancy, looking and maybe up 32 weeks, looking at the MRI, looking at the Dopplers, and take a decision regarding termination.
Jyoti madam?
Yes.
I have a question which is beyond academics. See, the monochorionic twins, they are friends inside the womb. They were playing together. Suddenly one fetus dies. And what are the psychological abnormalities in that surviving twin without which abnormality is not detected in antenatal scan? Number one, whether it can become a agori because it has lived with a dead fetus. So I want to know what are the psychological abnormalities.
Neurological abnormalities are most commonly seen because of this thrombus spreading onto the fetal brain. That is what is being studied.
I can answer this from a personal experience.
Yes,
I have
please.
One of my relatives who had this, and now like it was a triplets. We had reduced one fetus at 11 weeks, and then there was a fetal demise at 26 weeks. My own cousin sister's son.
Okay.
And then I had pulled on the pregnancy, and now he's in 10th standard. He's quite studious, like this. I had not seen any psychological problem, but unfortunately, he has a spastic diplegic cerebral palsy.
Okay.
For which we have tried a lot of treatment.
So that's what is the importance of doing MRI.
He is now 15 years.
Can't do anything.
So he's 15 years means appearing for SSC right now. So this was like in the start of my practice, and that time I had taken references from everybody, what is to be done. I was more scared about DIC and to the mother, to my cousin sister. From 26 weeks we pulled on till 35 weeks, doing the PT, APDT and everything. That time fetal MRI was not so much. I'm talking about 2005, 2004, that time. But he had this spastic diplegic cerebral palsy, for which he is taking physiotherapy and he has taken Botox injections. But psychologically, I have not seen any problems in last 15 years.
Madam, one question to you, Dr. Jyoti madam. Hello?
Yes, sir.
Yeah. How do you monitor single fetal demise, maternal monitoring? Is it only PT, APTT, or you want to measure even FDP, fibrin degradation products?
If the patient is developing pregnancy complication like preeclampsia, then definitely you have to do it. Otherwise, PT, APTT will suffice.
Okay. Most of the times, PT, APTT is enough. Okay.
Is FDP more important or serum fibrogen is important? Like even if it's a preeclampsia. USG, you know? USG, yeah.
USG, definitely.
USG, serum.
How frequently the USG? Every 1 month is enough? 4 weeks or more frequently?
2 weeks.
2 to 3 weeks.
What you want to exactly see in the USG? Whether it is causing any IUGR in the second fetal?
Yeah, IUGR, and also there may be thrombosis in the brain and also in the organs.
How will
so there may be IUGR may be there. Liker also may be reduced.
How thrombosis in the brain will be picked up by sonography?
You look at the Dopplers.
No. How will the that thrombosis in the brain of the other surviving fetus be picked up by
MRI only.
Only MRI.
Fetal MRI. Fetal MRI.
So how frequently fetal MRI should be done now in today's
Every
day?
3 weeks.
Every 3 weeks.
Every 3 weeks.
And what is the sign of termination? When should we deliver? What is seen in MRI which can be suspicious?
No, that
Dilatation of the
is not an
ventricles?
indication for delivery. That is only prognostication of that particular fetus, that it may have neurological sequelae. That the termination doesn't depend upon the development of the neurological abnormalities.
Okay.
Shalama madam, a question for you. Antihypertensive of choice. Antihypertensive of choice. First line antihypertensive of choice in a heart disease complicating pregnancy.
Nicardia can be given and labetalol also can be given.
Okay, is
But
there any contraindication
beta blockers are usually given in heart disease, but it is contraindicated in pregnancy because it can produce IUGR and also there is chance of reduction in the IUGR. So better to avoid beta blockers in pregnancy.
What about
Jyoti madam, one
lactation
question, I
while on
think
acid
I missed it. They have asked, one person has asked twin reverse arterial perfusion management, TRAP.
So they have already mentioned, no?
Okay.
Shalama madam, what about warfarin and lactation?
Yeah, there are
Warfarin already I mentioned, because warfarin, in one slide I mentioned warfarin should not be given in the first trimester. After 12 weeks, it should be up to 12 weeks, heparin should be given. After 12 weeks, warfarin can be started, and at 36 weeks again restart going to heparin, and after delivery heparin can be given. In the postpartum period, you have to start warfarin in the postpartum period. There is no contraindication for warfarin in the postpartum period.
Ma'am, there's a question from Dr. Manisha Ladad. Okay, how will you monitor the patient if she started on LMH or conventional heparin?
Sorry?
How will you monitor if she started on low molecular weight heparin or the conventional heparin? Is there any difference in the monitoring of the patient?
Difference, it is depending upon the advantage of giving this one. So if you are giving low molecular weight heparin, there is no proper monitoring except PTINR is there. But in the other cases, HIT can be there. That should be the monitoring
is only for conventional heparin, not for a low molecular weight heparin.
No, the conventional is.
One more question from Dr. Anuja Kulkarni. Is there any role for sildenafil in pulmonary hypertension?
What's that?
Sildenafil. Hello? That the cardiologists manage, they do normally give.
They give.
Yeah. But then how will we have to refer to the cardiologist?
For Dr. Jyoti, are prothrombin time or APTT or fibrinogen to be done in diamniotic monochorionic pregnancy with single fetal demise too as frequently like and monomin?
No.
Monochorionic.
No.
How will you substantiate that, ma'am?
Because there's no cross connections between, unless it's
this is for the mother's DIC, na madam? The monitoring of PT, IPTT and fibrinogen for the mother's DIC.
You can do it initially, but it's not necessary to continue monitoring that frequently.
Okay.
And unless if it is a fused placenta where you mistake it for a monochorionic, then the implications are there.
Okay.
What I will clarify, if there's a single fetal demise, we do the PT, APTT and fibrinogen is for the mother's health, right?
Yes. Yeah.
And we do the fetal MRI for the fetal
brain, yeah. And you carry the pregnancy till you want the fetus to be out.
So even if it is a monochorionic or dichorionic, I think the PT, APTT and this every 3 weeks should be anyway done.
Yes.
Because it's for the mother's health.
Yes.
Okay.
Viru sir?
Yeah, actually, the occurrence of DAC is very rare because given in Williams also that when the circulation is not there, how the tissue factor will be circulated into the maternal circulation. Yeah. So that is the argument in one of the papers in Williams obstetrics. Because there is no circulation.
DIC is not very common in early pregnancy. Early pregnancy is single demise. It occurs in late only. Then only that's DIC occurs.
Okay.
I think the questions are more or less over, right?
We have covered almost all everything.
I think I'm.
We'll wind up. So
I think I'm getting.
Jyoti madam, sorry I missed you because I was busy with an emergency, like one patient. So I missed the initial part of your presentation. I'm so sorry for that.
Yeah, all the three talks were excellent. Yeah, very
Thank you.
exhaustive
It's
coverage.
not that we still have a lot of questions coming, but then due to I think it's already 5:30 almost. We actually extended by half an hour, and again on behalf of the as a proud secretary of Calicut Society and as a proud president of Calicut Society, Jyoti madam and myself, and also senior members like Chelma madam, past president, Dr. Shekaran sir, Vinay Chandra sir, and a lot of other seniors, Sridev madam. We would like to thank each and every delegate who's logged in for this wonderful talk. We'll again have one more webinar very soon, but again, just reminding you for tomorrow morning, 11 o'clock, surgical management of fibroids, and also the decision making in the management of fibroids by three stalwarts, just like today what we had, Dr. Kurian Joseph, Dr. B. Ramesh, and Dr. Rajendra Sangpal. Please do join us at 11 o'clock. Okay, I will send you the links soon. Again, on behalf of Calicut Society and on my personal behalf, and my boss, Professor Shekaran, we would all like to thank you for this wonderful session. Thank you very much. Thank you.
Thank you.
Thank you,
So,
Subhash.
thank you,
Thank you,
for
Jyoti madam.
almost 2.5
Thank you, Dr. Virendra. Thank you, Dr. H.G. and Dr. Tamir. Thank you, Chellama
Thank
madam.
you.
Thank you,
Thank you,
Virendra
madam.
Kumar
Madam,
sir.
Thank you, madam. Thank you, Jyoti madam.
He's
Thank you,
on,
everybody.
he's on call today. His unit is on call today. He's got a lot of phone calls, but still he spared his time for us. Thank you very much, Viru sir, for
thank
staying
you.
back with us. Again, Dr. Reggie is on duty today, I believe. Thank you very much, sir, for joining us. Thank you. Thank you a lot.
So
Thank
during
you,
the period of COVID-19, we were all active. Thank you for
Wow.
Yes.
Thank you, Torrent Pharma. Thank you, Mr. Alok. Thank you, Maruti.
Thank
and
you,
every-
Torrent.
Out, Balaji, Mr. Reddy, and every one of the top knocks in Torrent Pharma for making this a wonderful session. Really proud of it. At the end of the day, I have 900 at the end of the day. I think my day is done.
Yeah.
I've forgotten all the pain that I've undergone in the last 48 hours after this wonderful session where we have about 900 people here. Thanks a lot. Thank you.
Okay.